Good evening, I'm Stefan Achenbach and welcome to Best of ESC Congress 2018. It's been 1 week since the Congress in Munich closed its doors, and this evening we will look back on the most important science presented there. Joining me in the studio for this live program are four good friends and distinguished colleagues. John Cam from London in the United Kingdom.
Hello, Stefan.
Hello, John. Eva Prescott from Copenhagen in Denmark.
Nice to be here.
There's Roxana Moran, who actually is from the United States, who came all the way over here to join us tonight. Thank you very much, Roxana.
Thank you for having me.
And my good friend Marco Roffi from Geneva in Switzerland.
Pleasure to be here.
We have two audiences. On one hand, 500 ESC professional members from all over the world are following us live on the internet. And on the other hand, cardiologists in 7 European countries have gathered to follow us as a group. So a special welcome to colleagues joining us from Latvia, Lithuania, Lebanon, Montenegro, Russia, Romania, and Serbia. But let's start looking at ESC Congress in Munich. I had the impression that the Congress offered a large range of scientific hot studies that were particularly relevant to clinical practice. And one such trial was the POET trial, extremely relevant to what we do every day in our practices, in our hospitals. In POET, 400 patients planned for conservative management of endocarditis were randomized to continuously receive intravenous antibiotics, such as we typically do, or to switch to oral treatment after 10 days. And the trial significantly demonstrated non-inferiority, meaning that the oral treatment, as you can see in these graphs, was just as good as intravenous treatment. Sometimes negative trials are perceived as being not useful, but here in this case we see the fact that there's no difference is some very valuable information for us.
I think it's really important for the clinician, this trial, because it gives a really good piece of information about sticking with oral antibiotics after the initial intravenous administration. It should make the treatment of endocarditis much easier, much simpler.
Much easier.
And it's so significant for developing countries where intravenous antibiotics are difficult to get to. And this is such an incredibly difficult disease to treat. And if you can shorten the hospital stay, send the patient home on oral antibiotics, it's a winner.
Even for West
for
countries,
us,
for quality of life for the patient and for cost. Implications are major.
But the patients were closely monitored.
So
it's not, it's probably just as intensive as having
They were closely selected. 2,000 patients were screened for inclusion, and then 400 were included. They were closely monitored, coming back to outpatient clinics every few days. It's certainly a step in the right direction, but not something that we can immediately, without thinking, translate into our clinical practice. But it's a trial that showed no difference. And a trial that shows no difference is not always a negative or useless trial.
Absolutely. Properly designed, properly powered, and it's a very interesting and good result.
But let's turn to our first topic group. That's interventional cardiology and coronary artery disease. And Roxana, you're going to present some trials on interventional cardiology and coronary artery disease.
Уважаемые коллеги, я еще не поздоровался, но если будут вопросы, вы их присылайте сразу. Мы не будем ждать окончания трансляции.
In fact, Roxana, you said that for you, the Congress sort of had a special motto. And then I thought it was an interesting thought. What was that motto that you recognized?
Well, I felt like it was sort of around the entire place where we showed time and time again that less is more.
Less is more.
And some of these negative trials actually have very important implications. And in fact, maybe they're positive, despite the fact that they actually don't meet the primary
endpoint. Maybe they're neutral rather than negative, which means they can be positive.
Neutral, it's a good one. So the global leaders is one that I think is extremely important. This is a 16,000 patient study, the largest of its kind. For interventional cardiologists, guys, this is a huge trial for us. 16,000 all-comers patients, no real exclusion. So it's anybody undergoing PCI. And the idea was, can we make the post-PCI dual antiplatelet therapy simple? Can we just give someone, every patient, ACS or stable coronary disease, aspirin, ticagrelor for a month. And instead of stopping the ticagrelor, let's stop the aspirin, withdraw the aspirin, and keep the patient on ticagrelor and follow them for 2 years. Put them on that for 2 years.
And I think it's, as you pointed out, important to see these were stable coronary artery disease patients and acute coronary syndromes, all treated the same way.
All treated the same way in a very simplified fashion, and a monotherapy for ticagrelor. The control arm was standard of care. So stable patients received clopidogrel, aspirin clopidogrel for 6 months, and then aspirin alone. And the ACS patients received 12 months of dual antiplatelet therapies per guidelines. Well, the primary endpoint, which was a very hard endpoint of all-cause mortality, so very easy to adjudicate that. You just, patient is alive or dead. And Q-wave myocardial infarction diagnosed by a core lab that looked at the all of the EKGs. Unfortunately, it didn't meet the primary endpoint of reducing mortality and MI at 2 years, but it was a superiority trial that failed to show superiority. Bleeding was no different.
The long mono treatment with ticagrelor was not superior, or barely not superior to
Barely
the
not
standard
superior,
dual
but take a look at this really shows. I mean, if you look at the slide and you look at the mortality, immediately about 120 days, you start to see a separation of the curves in favor of this simplified therapy. It doesn't meet the primary endpoint. We can't say this is what you could do, but I actually think for a negative study, this is very positive for simplifying our death
What
record.
about
But Roxana, I mean, maybe in retrospect, were the investigator too ambitious? Should have aimed for a non-inferiority trial, actually, because you say, okay, we are already simplifying the regimen, so maybe non-inferiority could have been also a goal. What do you think?
I 100% agree. I think non-inferiority for ischemic endpoint to say, for the first time, we're going to withdraw aspirin from your regimen and show is not going to be a problem. That's a massive
That would
thing.
be a
Well,
separate trial, though,
it's a
right?
separate
This is
trial
not what
now.
this trial did.
Yeah,
Nevertheless, very interesting data.
very interesting.
Keeps us moving in the right direction, making things simpler. I mean, maybe, as you say, less is more.
Yeah, less is more. And here's another negative study, complete separate field, transcatheter mitral valve repair using the clip for secondary functional mitral regurgitation in pretty sick patients with heart failure. This was severe secondary MR patients, about 300 patients randomized to medical management or the clip. And they were followed out to 12 months for a primary endpoint of all-cause mortality and rehospitalizations for heart failure. No difference whatsoever.
These were patients who had severe heart failure to begin with.
I
and
gotta
then
tell you,
secondary.
I was very shocked with this trial. I really felt, because both arms receiving excellent medical therapy, and the clip definitely reduces mitral regurgitation.
But actually, both group improved. So actually, maybe the surprise is that the medical arm improved that much. So one may question whether at baseline the patient were properly addressed in terms of medical management.
Yeah, I think
And
so.
there's a number of questions coming here. First of all, did it help them as far as symptoms go? And the investigators showed some data that symptoms were reduced by the
Yeah, there's no
mitral clip.
question. Actually, they did show there were less often patients found in class 3 or 4 heart failure when they were treated with the clip. But you know what? The bottom line is, though, look at these curves flat on top of each other for the primary endpoint of death and rehospitalization. That's what we treat these patients, these heart failure patients, for. If you can't show an evidence for that, should we be using the clip?
Then also, looking at the curves, you look at the numbers. 50% event rate.
Yeah.
These are extremely sick patients.
Yeah.
And that's something that needs to be taken into account.
If you can improve their quality of
50%.
life, that's also
event
worth it.
rate.
Reduce their symptoms.
And then there always the
Yeah.
thought maybe these patients were treated too late. Right? If you have severe heart failure, maybe the ventricle just cannot recover, even if you do
I
something
mean,
about
this
the
was a
mitral.
French group. There were 17 centers in France that did this, very highly qualified centers. So I think they did very good job with
Yes, the
their clip.
complication rate was
And
very low.
Very low, extremely safe procedure. We're going to see the next trial at TCT, COAPT. So
It'll
we'll
be
see.
interesting to see. Let's move to a different topic, Roxana. The next topic we'd like to cover is arrhythmias, and John Cam will let us know about arrhythmias.
Thank you, Stefan. I'm going to start with a relatively small trial, but it's a randomized controlled trial, and it's called APAF-CRT, and that stands for ablation and pacing in AF using CRT. And it's an interesting trial because we've had AV node hisbundle ablation for quite some time, but no really good randomized trials, and here is one. The patients who entered the trial were people who had narrow QRSs, atrial fibrillation. They'd been admitted in the last 6 months for an episode of heart failure, and they were unsuitable for ablation of the left atrium, or they'd had an ablation, or some reason why they were unsuitable for rhythm control therapy. So they were randomized 1-to-1 to the hisbundle ablation and pacing strategy, or to standard of care drug therapy. At about 30 days out from the start of the trial, there was practically no difference between the groups. They were very well matched, except that the drug-based group were receiving a bit more digoxin than the patients who were in the ablation and pacing group. If we look at the results, on the left we see the primary endpoint. It's death for heart failure, hospitalization for heart failure, or worsening heart failure, so it's a composite. And you can see that the group treated with the ablation and pacing strategy, the blue line, had significantly less endpoint events than those who were treated with the interventional
It does seem like a very large difference.
It is. The hazard ratio is 0.38, and as you can see, it's significant despite the relatively small numbers in the trial. And the investigators went on to look at what the contribution was of the various parts of the composite, and of course it was driven largely by hospitalization for heart failure, although there was a numerical difference in terms of all-cause mortality. It wasn't significant. But then I think we should turn to this subgroup analysis in patients who had a low ejection fraction equal to or less than 35%. And there, the divergence between the curves is really amazing. Hazard ratio is 18%, so that's an 82% relative risk reduction. And the patients who had the intervention did extremely well. And I think that this trial brings home to us that this relatively old concept, but modernized in the sense that there's good CRT associated with it, is a really good strategy for patients, not just at the end of the line, but we could adopt this therapy earlier, particularly in patients who have some evidence of impaired left ventricular function.
I think most of us had this in the back of our minds as a last resort. If there's no way you can control the heart rate, to then think about ablation and pacing, but this might move a little bit further up in our considerations.
Absolutely. I've been following that sort of strategy for years, just leaving it for those that I couldn't treat in any other way.
I get a little nervous about that, though. I know it's a very positive study, 80% reduction in low EF patients, small numbers of patients. You start to see from 360 days to 720 days, so up to, like, as you follow them, the curves are beginning to converge rather than diverge.
Some catch-up.
And so there's some catch-up. And then the arm that's missing here that I would have loved to have seen is just an AFib ablation arm, the kind of arm we see in Cabana that I'm sure you're going to talk about. So here we've got drug therapy with a very quick and dirty AV ablation pacing. Okay, this is better. I don't know that I'm not.
Well, let me remind
I'm not sold.
Let me remind you, some of these patients had already had a left atrial ablation. Others were deemed unsuitable for it, or they refused it. So they weren't candidates for that kind of approach. And secondly, of course, this is a relatively elderly group, and therefore, as you follow these patients, there are competing risks, and that probably accounts for why the curves become more parallel.
John, to be in line with the comment of Roxana, do you think that this is has to be seen as a definitive study that should lead to a change in management, or this needs to be confirmed by a larger study?
I think we would all like a larger study. Of course we would. And we'd perhaps like to use single endpoints rather than these composites. But I think that this is a definite marker that we have to pay more attention to this particular way of treating these patients.
And one particular question as far as practical implications go, would you then implant a CRT system and wait a while to see whether you have any loss of leads or whether you can really rely on the system and then ablate after 4, 6 or 8 weeks?
That's very much what is done at present. Many patients get the pacing system first. I don't think that there was any specific order to what happened in the trial. Although I'm not sure, but I think that in practical terms, you can certainly put the pacemaker in first, and then which applying the CRT might be an advantage. But remember, these patients all had narrow QRS complexes. That was an important inclusion criterion to try and minimize the advantage derived primarily from CRT.
Very interesting.
So perhaps I should go on to the next trial that I'd like to discuss. And I'm going to talk about 2 sub-studies from the Cabana Trial. Now, you'll remember Cabana itself, the main trial, was presented in May at HRS. 2,204 patients randomized 1-to-1 to either a left atrial ablation strategy or a drug-based strategy, either rate control or rhythm control, predominantly rhythm control. Any kind of atrial fibrillation, paroxysmal persistent, long-standing persistent atrial fibrillation patients went into the trial, but the patients were 65 or older, or if less than 65, they had risk factors for stroke. So the trial itself was neutral. It didn't show any advantage to ablation when analyzed on an intention to treat basis, but there were some controversial other analyses, an on-treatment analysis, according to what treatment the patients actually did get, and a per-protocol analysis. Now, of course, those are not, first, the primary analyses, and secondly, they destroy the concept of the randomization to a large extent. And the trial had to do that, so to speak, because there were a lot of crossovers. So be that as it may, what else comes from this trial? Well, these are the first 2 sub-studies to be introduced, and the first one is about quality of life. And you remember that we tend to ablate people for symptomatic reasons if they have atrial fibrillation. So this is really trying to document that. They did a very extensive quality of life assessment done by telephone from Duke, so not by the people working on the patient directly. They used lots of different instruments. On the slide, I've only illustrated the so-called Mayo AF specific symptom inventory, or MAFC, but they also used affect, various other instruments, and patient-reported outcomes. And you can see from the illustration that at baseline, the quality of life was similar in both of the trial arms, but that there was a significant improvement of quality of life as the trial went through. In fact, it lasted all the way through to 60 months, the end of the trial, and the quality of life improvement was greater in the ablation group than it was in the drug group, although the drug group also improved to some extent. So that, I think, is a trial which gives a lot of justification for what we are now doing.
I think they also looked at the recurrence rates, right? The recurrence rates of atrial fibrillation.
They certainly did, and that's what I would like to show you next. There was another sub-study that reported the results of very extensive Holter monitoring that had been done throughout the duration of the trial. The results pertain to after the so-called blanking period, so after 90 days following the ablation, and then you can look and see what recurrences there were on the one hand of atrial fibrillation, on the other atrial fibrillation, atrial flutter, and atrial tachycardia. The results are the same for both analyses. They're highly significant. You can see the recurrences are much less in the ablation group, that's the orange bars, than they are for the groups treated with drug, and that's the blue bars. But you can also see, and I think it's no surprise to many of us, that recurrences become greater and greater as the trial continues through to the end of the trial at 5 years. Now, you can also think of that as at least 40% of patients in the drug-treated arm didn't have any recurrences, as documented in this way, and some 50% plus in the ablation group didn't have any recurrences. But again, I think it's not a surprise because we know that ablation does reduce the atrial fibrillation burden. And incidentally, that was also demonstrated very nicely by this whole series of
I think you can sort of look at the glass as half full or half empty, right?
Absolutely, and I think we have to think about the half full bit as well, because I think it does justify to a large extent the reason for ablation. It is to abolish or eliminate recurrences of atrial fibrillation and to reduce the burden. But this also reminds us to be very cautious about what we do with that data. Don't let's think we can stop anticoagulating patients, for example.
Because we find 50%, if you look closely enough, the harder look, the more you will find. And these investigators looked very closely with 96-hour periods of Holter monitoring, if my memory serves me right, whether any AFib was still occurring.
Yes, they did really extensively.
Right? So despite having ablation, you still need to, even if you get rid of the AFib at face value, you need to anticoagulate these patients. I think that's one of the points you're making. But this trial reminds me so much for us interventionalists of the COURAGE study. When the COURAGE study first came out, and this was PCI versus medical therapy, and it showed the hard endpoints was negative, we were all very upset looking for some subgroup that was going to show some benefit. But the truth is, what we're seeing here is that quality of life is tremendously improved, and it's durable out to 60 months. That's very significant. And recurrence rates are reduced, just like we improve quality of life with PCI and reduce recurrence of angina and hospitalizations with PCI. So if we didn't reduce death and MI, well, in stable patients, well, that's really what we need to make sure and take away. And it's, in some ways, I feel like it's the same, no?
Exactly. So I think this is completely true what you're saying. And I think quality of life is something which is very important. But I think the message here is that people should continue anticoagulation, and actually the protocol mandated, if I'm right, anticoagulation in both arms. So
yes, it certainly did. And I don't know the exact number of patients or percentage that were anticoagulated, but I'm sure it was very high because
so
the
if you had
trial
AFib, would you go for ablation?
Depends on the symptoms, to be honest.
So if you had symptomatic AFib in a young person, I think, what do you think, Eva?
The quality of life is worth going for. I'd like to see whether whether this was correlated, whether the ones who avoided recurrence of AFib were the ones who had improvement in their quality of life.
That I'm sure is to come, but it's not with us at the moment.
It's to come.
I only have one other study that I'd like to talk about today, and that is, I think, a really interesting study and a sign of what's to come in the future. It's called the Digital AF study, and it was done in Belgium.
Well, anything that has the word digital in it sounds like the future, right?
Absolutely. Well, I think this is. You know that there's a great ideal of trying to screen patients for atrial fibrillation, to pick them up before they present with ischemic strokes and so on. So we need quick, simple, and relatively cheap ways to do this. Now, this was an attempt to at least lay the foundations for doing that kind of thing. It was called the first world mass screening technique. Now, it wasn't done all over the world, just in Belgium, but it was really simple.
Which is almost the entire world.
Oh, almost, yes. Certainly the European world is centered there. But what they did was put an ad in a local newspaper and ask people if they would like to use their smartphone to screen for this rhythm disturbance. And the whole technique depends on putting your finger over the camera of the smartphone, and then the camera can do a photoplethysmograph, and from that you can work out the regularity of the heartbeat, any irregularities, and strictly speaking, you can, with sophisticated algorithms, find out whether it's the kind of irregularity which is likely to infer that the patient has atrial fibrillation. So 13,000 patients.
For example, I interrupt you, John. So this methodology would be able, for example, to rule out extrasystole?
Oh, technically, yes, of course, because extrasystoles have a definite pattern. They're almost always linked with a fixed coupling interval and then a common post-compensatory pause and so on, so that you can normally work out what the cause of the irregularity is, in the majority of patients anyway, and it will get better and better. But they did over 120,000 traces, and from these they found 136 participants in 300 and something traces where atrial fibrillation was present. So this was a very quick way of finding out who had atrial fibrillation. Some of it was paroxysmal, meaning that the first time or the second or the third time they sampled the heart rate, it was regular, and other times it was irregular due to the atrial fibrillation.
So maybe we can have a look at the slide again, because we really have to consider the numbers here, John. As you think, I think this is interesting because it demonstrates that this technology can be used, right? But we have 12,000 patients and we find AFib in 136. So this is not something that puts us, gives us evidence that screening is good. It just shows us that screening can be done using this technology.
Yes, of course, but remember that there was no consideration of what age the patient should be, for example. And there were many, many young responders in this particular survey. If the investigators had said you've got to be 60 or 70, they would have had a much higher rate of finding atrial fib.
And another point of concern to me is, we have all these offers now that some technology can screen your heart for this and that, but in the end, some verification will always be necessary. And here you find, if you look at the numbers on this slide, 12,000 possible irregularities, and then 136 actually had AFib. So somebody had to do a lot of manual checking, I guess. And this is something that I think like a wave might hit us at some point in the future with all these automatic detections with mobile devices and so on.
Well, I agree. But on the other hand, the technology is becoming much more sophisticated. Every big technology company is getting involved in this, what was originally called health medicine. But now it's getting involved in illness medicine, and they're very keen to find out who has atrial fibrillation in a very simple way.
Provocative, we can say that it's not yet quick, but for sure it will become quicker in the future.
It certainly will.
Next, we would like to turn to the topic of prevention, which is also very important, obviously, and Eva Prescott is going to let us know what was hot in prevention.
So the PURE study was a very large study, worldwide study, looking at an observational study, looking at diet all over the world and following these participants for outcomes, CVD outcomes, all-cause mortality, different causes of mortality.
Unbelievably large, right?
Unbelievably large. And the important thing is that it moves away from just looking at Western diet to looking at diets worldwide, and then taking out the components of the diet and seeing which can explain differences in cardiovascular disease and other outcomes. So this was presented last year. The controversial findings were presented last year, showing that saturated fatty acids are good for you, and also showing some controversial findings around fruit. But what they presented this year was the diet quality score, where they summed up different...
So a score to assess how good your diet really is.
Yes, and then trying to validate it in other worldwide studies that they had. But there's 7 components. There were 7 components in this score they tried to validate. And the 2 controversial components were dairy and unprocessed red meat. And these are controversial because normally we think that dairy fat...
Red meat is bad for you?
Red meat is bad for us. Well, we think unprocessed may be neutral. It's bad for the environment. We know now we shouldn't be eating too much red meat. But they've, in the PURE study, they found that the more unprocessed red meat you eat, the better. And they also found the more dairy you eat, the better. So
dairy includes things that we traditionally conceive as really bad, like butter, for example.
Well, we usually think that dairy fat is bad, and that whatever you substitute it for, unless it's saturated fatty acids, then it's better. That's what other trials have shown, other studies have shown. But the PURE is controversial. They show that they find that dairy is good for you. So they put this into the diet score. And sum it up, and then they divide into 5 groups according to this diet score, and find, as you can see on the slide there at the top, that you get quite a good dose-response relationship with the increasing diet score for mortality, But what you see at the bottom there is that there's virtually no association with major CVD or with myocardial infarction. And this is
So that
somewhat
means
contrary to what we would expect.
diet
And also,
doesn't influence cardiovascular problems, but it influences other causes for mortality. Is that what we're trying to extract from this data?
at least this diet score doesn't predict cardiovascular disease.
So it makes me think of the validity of the diet score. If it doesn't really correlate well with cardiovascular disease, is the diet from the PURE studies, which was global studies, more reflective of low income versus high income countries? And is it the low socioeconomic status of a patient that actually dictates all-cause mortality associated with the PURE diet? That's what I got. I know you were the discussant, and you did a beautiful job, by the way, and I know that this is work of Salim Youssef and colleagues, and they always do fantastic work. But this really kind of confused me. It just basically showed me that this quality score actually doesn't really correlate
But
well.
I'm sure
Look
they
at the
must have
curves.
used some
They
adjustment.
have adjusted for
all of
socioeconomic
these
factors.
Did they adjust for age?
But you know, they've
But you can
I think
never
they've
adjust
adjusted
for
for
everything.
The thing is, can you ever adjust? This is, I mean, it's huge, but it's still an observational study,
Right.
and there are a lot of fallacies in observational studies. So.
And especially with nutrition, right?
And can
Adjusting
you
for
just from
confounding
observational
factors.
studies say, all the evidence we have also about saturated fatty acids and so on, we have mechanistic studies also. We have studies that when you change your diet, you have the effect that goes in the right direction. Is it enough to say that from this huge observational study we can draw a causal inference? I'm not
But at
sure.
least we should challenge our conventional thinking, right? The
It's always nice to be challenged. I'm not so happy that now if the media gets, the media like these diet stories. If the media go out and say now you have to eat more unprocessed red meat and more dairy, that's going to be counter to what we say about the climate. And if we're not sure about the data, it has to be modified.
It
when
has to be
goes out the
digested
press.
like a good diet.
Has to be digested, yeah.
That's okay.
And if the whole world is going to eat more red, unprocessed meat, that's not.
That's not going to solve our problems.
That's not going to solve our problems, and I don't think there's enough data to say that it's going to reduce our
But there was
cardiovascular
a
disease.
lot more about prevention at this
Yes.
ESC Congress.
Yes.
Really important data.
Really important. Aspirin in primary prevention. We're sure about aspirin in secondary prevention, but in primary prevention, ESC guidelines say we shouldn't be giving it, and other guidelines.
Yet, if I may interject this, a lot of people are doing it.
A lot of
Taking
people are doing
aspirin
it.
for primary prevention is
Yes.
very common.
Yes, and when we see them, we don't really know whether we should take it away or we should, because we all believe that there must be some sweet spot there, patient at high risk in primary prevention who would benefit from aspirin. And these studies try to look at that. One, the ASCEND trial was only in diabetes patients, 15,000 patients, and ARRIVE didn't have the diabetes, but it was in moderate
So based
patient
on
age.
conventional risk factors, moderate risk,
Age
then
and conventional risk factors. Randomized to
aspirin
100
or
milligram aspirin versus placebo and followed for a number of years. And the ASCEND showed exactly what we'd expect. There was a benefit on the vascular outcome, the combined vascular outcome, which was precisely what previous combined studies have shown us, a 12% reduction. But it was counteracted by the increase in bleeding. So that was
you said
an
12% reduction.
Yeah, which translates into 1.1%.
Absolute reduction.
Absolute reduction.
If you treat these patients, you have 1% less vascular events over the time period of about 7 or 8 years, right?
Yeah.
But, as you say...
But 0.9 major vascular bleeds.
Bleedings.
Yeah,
Okay.
in the
So
same
is that really
So-
worth it?
Well, the cardiovascular benefits are counterbalanced by bleeding risk.
Yes, but you can discuss. Can you find a patient who's got very low bleeding risk? You might go for the benefit, but they already took out patients at increased risk of
Diabetic
bleeding.
patients are not necessarily at high risk for bleeding, depending on, because you're usually younger.
Yeah, but they had higher risk. They had the bleeding outcomes had a higher rate than in the ARRIVE study.
Yeah, and actually, in general, diabetic patient, even in the ACS study, bleed more than...
Yeah, they've got retinal bleeding and so on
what's
also.
important, I think, in both of these studies, that aspirin did not reduce cardiovascular mortality, even in the ASCEND study in diabetic patients. Cardiovascular mortality, which was one of the composites, was no different. Or am I wrong?
All-cause mortality certainly wasn't different.
Was not different. Neither was CV mortality. I
Yeah,
don't think.
cardiovascular events, MI, were lower. but cardiovascular mortality was not.
Both studies had to extend both the outcome and the duration of because they were.
But the fact is, we have two large trials which sort of really hard looked at the question whether aspirin may be useful in primary prevention. No evidence was found. So these were really two trials that make us have to reconsider the use of aspirin in primary prevention. Less is more. Interestingly, the presenters of the ARRIVE trial talked about the drop-in problem. Right, the data were made a little bit difficult because I think 40% of the control group were given aspirin during the course of the study for prevention reasons that are really not based on any
they did per protocol analysis, which showed a huge reduction, a large reduction in myocardial infarction, for instance. But then you're no longer looking at a randomized trial.
That's true.
So I mean, can you really interpret that?
And it's the balance, benefit as far as cardiovascular events is concerned, risk as far as bleeding is concerned, which means if we want to ever use this, we really have to find the right patient. The high cardiovascular risk patients and low bleeding risk patients. We have to find the right patient for this treatment. And this brings us to another trial that stirred the interest of many of us looking at this problem.
That's the Scott-Hart trial. The Scott-Hart trial it's been presented before, but here we had the long-term outcome of the Scott-Hart. And the Scott-Hart trial is a study looking at all comers suspected of coronary artery disease with angina or angina-like symptoms. And they were randomized to either standard of care, which was mainly exercise testing.
Treadmill exercise testing, EKG
without,
testing, right?
Without imaging, And the other arm was CT angiography.
It was done in addition, right? That's important to note. In addition to the standard of care, an additional CT scan.
That's right. And at the beginning, they found initially there was more revascularization in the CT angio group, but this was evened out over time.
So that's interesting. They ended up because there was 2-year data was presented a while ago, and there was more revascularization in the CT arm, and that fits with previous trials. And everybody was saying, CT leads to revascularizations, but then after 5 years, you said there was a catch-up. And the revascularization
they ended up having similar revascularization rates, yes. But the outcome they presented here was a large reduction in the combined endpoint of coronary heart disease, death, and non-fatal MI.
Yeah, here we see the graph again, and you see the tremendous difference in these curves.
41% reduction, and that was, and then you had to try and look for an explanation for that, And one explanation that was probably the main explanation is that when you have the imaging, you know that the patient has the disease, even if they don't have obstructive coronary artery disease, and you treat them with statins and you treat them with aspirin. And there was a 10% difference in both statin treatment and aspirin treatment.
In the amount of patients treated, right? In the CT arm, at the end, 50% received statins. In the conventional arm, at the end, 40% received statins. But I think that's not the only, I'm very much pro-CT. I think that's not the only difference. I think it's not about how many patients get the treatment, but whether the right patients get the treatment. And that might have been directed by CT.
Yes, right? That's right. But still, it's difficult to explain with only 10% difference in both aspirin and statin that you get a 41% reduction?
Well, let me defend this a little bit more. Yes, we see 10% more use of statins, but as I said before, maybe we're giving it to the right patients rather than randomly giving it to the entire group, giving it to the right patients. And you correctly point out that there was a 40% reduction, but it's a 40% relative risk reduction, and the absolute reduction was 1%. So about 3% event rate in those who had no CT, and about 2% event rate in those who had a CT. So 1% event reduction, highly significant, 40% relative reduction. But why not explain a 1% benefit by treating the right patient with statins based on a CT?
It's possible, but then you also have how good was the treatment in the control group? First of all, it was exercise treadmill, as you say.
Not the standard of care.
I mean, we still have the PROMISE trial to compare with also. We didn't see this difference in the PROMISE trial.
Eva, I have a question, because was there the fact of the people knew if they had coronary disease? So there was any changes in terms of lifestyle from the patients, or maybe they were exercising more, or they were more conscious in terms of diet, or?
That's a good point. I haven't seen that data. I don't think it was in the publication.
It's not in the publication.
No, so they did do different things, right? So if angiography and you had coronary disease, you were given a letter to your primary care physician and your cardiologist that this patient does have. So I think this trial tells you that knowledge is power. A picture is worth 1,000 words. You understand better about the patient's pathobiology. You might be listening more to their symptoms. You are taking better care of them. That was
disease in their coronary arteries, at least a significant proportion. Something about it as far as they can do, as well as their doctors responding
I think
to
this
it.
is a I don't know. I'm just
It may be a game changer, but this is, we're moving into primary prevention, and because these patients didn't have obstructive coronary artery disease, but you image that they do have some atherosclerosis. And the question is, of course, and David Newby, who presented it, was also talking about the Scott Hart 2, where you move into asymptomatic individuals and see if a CT angio changes, it directs the treatment better, and also
that's speculation because the event rates in asymptomatics obviously are a lot lower than in symptomatic individuals.
I would be very interested now the opinion of you both. So your CT and prevention. So because this we encounter every day. So the patient comes in with some kind of imaging, is completely asymptomatic, and now the question is how should we treat this patient in terms of statin? And I know it's not
answered by the trial.
I know, but I wanted to know what is your view of that.
I can give you one view. Definitely no aspirin. That's ascend and arrive. No aspirin. If you think about something, give statins, but no aspirin.
Yeah, but then if you do a CT angiogram, then you need to give them a statin to be able to explain this huge difference.
Yeah, that's what I said. You know, the statin based on ascend and arrive. My extrapolation is that if you see this, if a scan has been done and you see plaque, be generous with the statin, but be very reluctant with the aspirin. That would be my conclusion from synthesis from what you have told us, and maybe consider some red meat.
Except patients don't like to get off aspirin or the fish oils. They don't like to get off those things. Even they go, well, it's not doing me any harm. But maybe the bleeding might make them change.
Yeah. There's one question that came in from the audience. Most of the questions that came in we've already discussed, but here's a question that says, do you think that using aspirin by small doses for primary prevention might have benefits if you use smaller doses that outweigh the bleeding risks? That the smaller doses would be better.
Well, there was this paper prior to the ESC showing in the Lancet discussing the weight issue, whether we're giving it. I don't think it's smaller doses. It's more being larger doses.
What has been discussed is that the dose maybe is not enough.
But this wasn't in the Ascend. It was the reverse. That it seemed to be that the ones with the higher weight had more benefit, and in Arrive it was the where you expected that if you've got a lower BMI, a lower weight, then you get more.
But at least the data that we saw in these trials does not lead us to the conclusion that smaller doses of aspirin might be beneficial because they have good effects and avoid the bleeding. That's something we don't know anything about. Let's move on to the next topic. And the next topic will be acute coronary syndromes, covered by Marco Roffi.
So, Stefan, this was an exciting meeting also in terms of acute coronary syndromes. And the first trial I would like to present you is the one-year data of the culprit shock trial. We have to remember, until last year, the general consensus based on some observational data was that in patients presenting with acute MI, cardiogenic shock, and multivessel disease, the consensus was to treat all the vessel immediately, so to hope to give the best chance out of the patient. But last year, Holger Thiele presented here and published in New England Journal of Medicine the culprit shock trial, the 30 days primary outcome. This is a trial of 700 patients with cardiogenic shock, acute MI, and multivessel disease, randomized to culprit-only PCI, with the option of doing a stage procedure during the hospitalization or immediate multivessel PCI. And actually, with surprise of many, the study was in favor of a culprit-only PCI for the primary endpoint was a death or a renal replacement therapy at 30 days, and even for mortality. So now we have the one-year data showing that actually the benefit in terms of death or renal replacement therapy is maintained.
There was no catch-up phenomenon.
And there is even a trend in favor of mortality. And so this really supports the concept that in patients with multivessel disease, you should focus only on the culprit vessel. Obviously, the patients that were randomized to the culprit-only arm had more revascularization in the first year, and also somehow more hospitalization for heart failure. But overall, the benefit is for sure in terms of culprit-only PCI. And for me, also one important data that I saw from the trial is that the rehospitalization for heart failure was very low, less than 5% overall in the trial. So if you survive shock, then the possibility of coming back the first year is very low.
Maybe we can have a look at these curves again, because I think we can take two conclusions from these curves. One is, as you said, there is no catch-up phenomenon. The curves separate early on, but after that, the curves run really parallel.
For sure.
So
there was even a landmark analysis showing that actually the benefit is limited to the first months, but there is no, let's say, difference after the first month.
But the other conclusion is that we're still doing terribly poorly for these patients, right? We have a 50%, basically 50% mortality in patients who come in with cardiogenic shock, with multivessel disease. So these are patients where really we have to try very, very hard to make progress in how to treat these patients.
And
maybe
actually,
mechanical support and all of these things which were not included in this trial.
For sure. And actually, the investigator really have to be complimented, because to perform such a trial is very difficult. The patients are very sick, randomize them in acute phase is really remarkable.
It's a fantastic trial, and it's a very valuable trial, because it's counterintuitive to what we would think is the right thing to do, revascularize as complete as possible. Is this also something that will change strategies in the US?
Yeah, no, there's no question that the early data with the culprit shocks trial turned the wheels completely for us towards just focusing on the culprit. And I really think we have to do something. 56% death rate in complete revascularized patients in 1 year after shock. It's something else that we need to do. And I think the idea of a unloading before PCI is one. I know that there's been a lot of balloon pump data that's been out there. And I just think we really need to focus on this area, cooling, all these other
we have to try as hard as we can.
But we can just take care of the culprit.
So we have to admit that we have very limited options with those patients. And all these other options, like vasopressor and even assist devices, for the time being, there is no data. All have a 2B indication. But clearly, especially, we all know in our experience that sometimes an assist device is the only thing that can make survive those patients, and probably putting those assist devices early on, before the multi-organ failure, is the way to go. But clearly, this needs to be addressed in a trial.
What this trial tells us is that you limit yourself. Less is more.
Less is more. Like, here we go.
Limit yourself to the culprit lesion, at least for routine treatment of these patients who come in cardiogenic shock.
So the next study I want to show you actually is not a randomized trial, but is a registry. And this shows really the fact that for some condition, registry are very valuable. This is a registry from Canada on spontaneous coronary artery dissection. And actually the investigator put together the data prospectively of 750 patients.
That's a large group of patients.
Enormous. And we all know how difficult is the management of those patients. And we have already some interesting data in the baseline characteristic. Many of us would think that the typical patient is a very young lady, maybe following pregnancy or during pregnancy or delivery. But actually, this registry showed that the mean age was more than 52 years.
A lot older than you would typically
expect. Exactly. It is true that almost 90% were women, so this holds true. But 50% of those were postmenopausal. So we have to go back away from this idea that this affects only very young women. And so the clinical presentation, also interesting, 1/3 STEMI, 2/3 non-STEMI.
There were even, I think, about 6 or 8% who were in ventricular fibrillation or rapid ventricular tachycardia. So these can be very dangerous conditions.
Exactly. And then we have also some very interesting angiographic data, because we don't have all this data. And actually, the LAD was affected in more than 50% of the cases. The vast majority was a single vessel coronary dissection. And the especially high-risk conditions such as left main dissection were less than 2%, or proximal segment were also rarely affected. So this is the good way of thinking. But for me, the most important is to see how those patients were managed, because we know that when we go to the cath lab and we see a patient with ongoing ischemia, and we see coronary dissection, we are really puzzled how to do it. The first thing is that the vast majority of patients were treated conservatively. So almost 85% of them were treated conservatively. And so PCI was done rarely. And actually, among the patients who received PCI, 1/3 had a successful PCI, 1/3 intermediate success, and 1/3 no success or even worsening.
Yeah, that's because these lesions are very distal, small vessels.
So I think the first message is here. It is we should try in every way you can to treat those patients conservatively.
I think the first message is that this disease exists, because not everybody knows about the disease. Spontaneous coronary dissection is sometimes
Is
not
it often missed?
not recognized
Often
angiographically.
Yes, I mean,
in both ways. It is missed and it is misinterpreted as a normal atherosclerosis. That's the two things that are happening.
We have
And
to
especially
admit
in women, right?
Yeah.
Underdiagnosed. And again, here, showing again, don't intervene, because you end up just stenting and the dissection propagates. It's extremely difficult to treat these patients, and conservative management showed not a very high death rate, 0.1%,
Exactly.
although
This
they
is-
had high rate of.
this is the next point, which is very
Reinfarction.
important, is actually the outcome in terms of mortality at 30 days was great. So one patient out of 750 died.
In the hospital. I mean, these are patients who made
No,
it to the
until
hospital.
30 days.
Yeah, but these are patients who made it to the hospital. We don't-
Like all the, obviously, if the patient has sudden cardiac before, we will never know about it. But once the patient comes in, the mortality is extremely low. And this is really something which is good to know, especially if you embrace a conservative treatment. Sometimes you feel bad, you think you have to act. But as Roxana just mentioned, even here, less is more.
So this trial, this registry encourages us, if we proceed conservatively, that we can generally think that this will have a good outcome. And this is what this registry
So I
does.
want to give a shout out to Jackie Saw, who on her own basically put this Canadian spontaneous coronary artery dissection registry together, because she's very concerned about heart disease in women. And this is really a very, very important cause of heart, non-atherosclerotic heart disease in women. And we have to recognize better. And she did this using social media. There is, I know that there's a Facebook group that are, all of these patients are actually talking to each other and are within this this registry, have a Facebook group that are really connected. So again, innovative, a woman investigator looking after heart disease in women, finding out a lot about this very underdiagnosed and undertreated disease.
And yet clinically important.
Extremely
Clinically important. I think this brings us back to the beginning, where I said that at this ESC Congress, which not only sort of transported a very special spirit and atmosphere, but it also brought us so many trials which were of clinical relevance, starting from POET with the endocarditis at the beginning, all the way to the coronary dissection, primary prevention, arrhythmias, AFib. So I thought this was a tremendously important and valuable issue of ESC Congress in this year, 2018. So this concludes our round of this presentation and discussions among the five of us. And I would like to thank you all extremely for your fantastic insights. And I would also like to thank the online audience for following us. In the 7 national cardiac societies following us live, you will now have time to digest what has been presented, to discuss among yourselves, and to prepare feedback and questions to the panel. And we will be back live in about 45 minutes, and we very much look forward to hearing from you then, and to answer your questions and get your feedback.
And actually, I'm allowing to interrupt you.
Please do so.
Because I would like to use this opportunity to thank you. This is your meeting. You did a fantastic job. And really, you need to be congratulated for this.
Well, thanks a lot.
Excellent.
That
Thanks.
was an amazing meeting.
It was a joint effort
Congratulations.
like this evening. Thank you very much, and I look forward to seeing you back in 45 minutes.
Уважаемые коллеги, добрый вечер. Меня зовут Сион Мацкеплишвили, я кардиолог из Москвы. И сегодня для меня большая честь модерировать по предложению Евгения Владимировича наше обсуждение того, что мы услышали сейчас. Мы, конечно, можем долго обсуждать Конгресс и те данные, которые были получены. Многие из вас были на Конгрессе или следили за Конгрессом с помощью онлайн-трансляции. Но вот у нас сейчас конкретная задача. Мы должны обсудить то, что нам было представлено, и дальше мы можем, после того, как все мероприятие закончится, продолжать обсуждать и Конгресс, и другие остальные темы. И самое главное, мы должны сформулировать вопросы, которые мы зададим нашим коллегам, находящимся в Париже, и они попытаются на них ответить. Мы должны засыпать их вопросами, и уже много довольно вопросов поступило через интернет на наш сайт от коллег, которые смотрят эту трансляцию, участвуют в мероприятии в нашей стране. И таким образом, если есть какие-то вопросы, вы можете задавать, мы будем их группировать и затем отправлять с помощью Екатерины в штаб-квартиру Европейского общества. У нас очень интересные были темы затронуты, практически вся кардиология, начиная от инфекционного эндокардита и поражения митрального клапана, и большой раздел по нарушениям ритма, большой раздел по профилактике, очень интересные данные по аспирину, я думаю, мы их обсудим. Ну и, конечно, по интервенционной кардиологии. Кто бы хотел задать вопрос по услышанному? Но это вопросы не мне, как вы понимаете, а это вопросы нашим коллегам. Ну вот первый, чтобы вас немножко активизировать, здесь много молодежи, не стесняйтесь. Катя, мы можем узнать, какие вопросы к нам поступали? Вы переоцениваете мое зрение. Да. Например, такой, сколько их вопросов-то. У пациента, это клинический случай, у пациента 54 года, через месяц после РЧ легочных вен, рецидив фибрилляции предсердий, выявлен тромбоз ушка на фоне приема варфарина при нормальном НО, гипертиреоз, возможно, кардиорон-индуцированный, гормон щитовидной железы не превышали нормальных значений, кардиорон отменен 2 месяца назад. Значил тирозол. Хотелось бы узнать мнение экспертов относительно дальнейшей тактики ведения. Такие вопросы мы не можем сейчас обсуждать, поскольку это вопросы, не относящиеся к темам, которые были затронуты. Мы их можем обсудить потом, если это интересно, если кто-то останется, поскольку будет уже позже. Сколько всего можно повторно делать ФРЧ, аблацию при неполном эффекте у больных с рецидивом фибрилляции предсердий? Если спросить аритмологов, это можно делать практически бесконечно. Тем более сейчас есть кривоаблация, не только радиочастотная аблация. Добрый вечер, спасибо за возможность. Добрый вечер. Какие позиции четвертого универсального определения острого инфаркта миокарда, принятого на Конгрессе? Ответим после. Каковы были основные позиции четвертого острого инфаркта миокарда? Спасибо. Много благодарностей. Очень много вопросов по четвертой позиции, по определению острого инфаркта миокарда. Добрый вечер. Скажите, пожалуйста, какие нормы артериального давления для здоровых пациентов? Здоровый пациент – это уже такой оксюморон, я бы сказал, немножко, да? И действительно были приняты рекомендации по артериальной гипертензии. Они были представлены на Европейском конгрессе по гипертензии весной и повторены здесь. И чтобы долго не говорить, 140/90 – это максимальное давление, которое должно быть у наших здоровых пациентов. Какие НОАК возможно назначать диализным больным? Спасибо. Мы назначаем им варфарин обычно, или они обычно... Да, давайте. Сейчас тогда дочитаю быстренько. Какой НОАК предпочтителен при рецидивирующем или феморальном тромбозе? По-русски, вы же нам задаете вопрос.
Достаточно интересная тема, связанная с применением пероральных препаратов для лечения инфекционного эндокардита.
Да, согласен.
Я хотела бы акцентировать внимание на выборке, которой назначался пероральные препараты, потому что эти пациенты имели низкий риск осложнений, низкую активность воспалительного инфекционного процесса и обязательно мониторировался уровень антибактериальных препаратов в крови. В этой ситуации возникает вопрос. С учетом того, что эти пациенты имели разные инфекционные микробные агенты, вызывающие инфекционный эндокардит, какие пероральные препараты чаще всего были использованы в этой группе исследователями?
Отличный вопрос, я его полностью поддерживаю, я думаю, мы можем его прям задать сейчас. Да, вот в принципе, я его написал по-английски. Очень хороший вопрос, потому что важная тема инфекционный эндокардит, смертность в лучших клиниках, один из лучших центров в Марселе, 40% в течение 1 года. Хоть у нас есть современные антибиотики, и мы активно пропагандируем раннее вмешательство, хирургическое вмешательство при эндокардите, чего, к сожалению, категорически нет в нашей стране. Тем не менее, смертность очень высока. В России пациенты с инфекционным эндокардитом не лечатся в кардиологических клиниках, они лечатся в инфекционных или в общетерапевтических клиниках. Кардиохирурги говорят, что мы не будем оперировать пациента, пока не будет нормализации температуры. Это совершенно недопустимо. Мы должны оперировать, если есть 3 главных показателя. Это большие вегетации, если гемодинамическая нестабильность, то есть острая клапанонедостаточность митрального или артального клапана, поскольку это 2 главных клапана, которые поражаются эндокардитом. И третье, если это системный инфекционный процесс, который мы не можем контролировать антибиотиками. И вот ни в одной из этих ситуаций кардиохирурги не оперируют ни при сепсисе, ни при острой митральной артальной регургитации, ни при больших вегетациях. Это заканчивается либо эмболиями, либо просто смертью. Очень хороший вопрос. Какие еще вопросы? Отправили? Да. Да. Which drugs should be preferred in this situation? Так, в европейских рекомендациях по гипертонии какая использована градация степени артериальной гипертензии? Заранее спасибо. Очень важный, интересный вопрос, но это не обсуждалось в данный момент. Каковы по итогам Конгресса принципиальные изменения по взглядам на вопросы профилактики внезапной сердечной смерти? Это, естественно, обсуждалось, но не в данной ситуации. Какой НОАК предпочтителен при рецидивирующем илиофеморальном тромбозе на фоне хронической венозной недостаточности, ПТФС? Онкологии нет. Спасибо за ваши трансляции. Это вопросы, которые пришли с нашей стороны. Мы будем дальше их собирать. Какие вопросы вот по эндокардиту? Что-нибудь можем их? Потому что у меня такой же вопрос, я сам себе записал. Естественно, мы назначаем антибиотики, исходя из того, какой инфекционный агент. И не для всех инфекционных агентов есть пероральные формы антибиотиков. Поэтому нельзя сказать, что здесь была такая идеальная рандомизация, я бы сказал. Но вот вопрос, который был задан, какие препараты, он очень принципиален, поскольку мы иногда назначаем эмпирическую терапию при инфекционном эндокардите, особенно если есть там 5 микробов, там ХАЦЕК определение, 5 специфических микробов. Если мы высеваем этот микроб из крови у пациента, то мы можем гарантированно ставить диагноз инфекционного эндокардита, даже если нет эхокардиографических проявлений эндокардита. Это можно почитать, очень интересная история. Затем были представлены очень интересные данные по... Да, вот до микроклипа они еще обсуждали... Да, ну это, наверное, интересно. По микроклипу, то есть пациенты, которые рандомизировались на оптимальную медикаментозную терапию против установки митроклипа, то есть это устройство, которое соединяет средние сегменты передней и задней створки митрального клапана, создавая так называемый двухпросветный митральный клапан, может быть с небольшим стенозом, но чаще всего устраняя или снижая степень митральной регургитации. И мы прекрасно знаем, что при митральной регургитации, при клапанных пороках сердца мы обычно либо ждем непонятно чего, либо отправляем пациента на интервенцию. Это может быть хирургия, это может быть интервенционная кардиология в виде митроклипа или ТАВИ, это может быть установка специальных устройств, которые сужают фиброзное кольцо митрального клапана через введение определенных металлических каркасов в коронарный синус. Но тем не менее мы знаем, что клапанные пороки сердца не лечатся консервативно, они лечатся только хирургически. И вот такие неожиданные результаты, что у пациентов, которые имели тяжелую степень митральной регургитации, получились такие же результаты, как у пациентов, которые лечились консервативно, такие же результаты, как и при использовании вот этой метроклипс. Вот какие будут вопросы и соображения, поскольку это очень важная тема, мне кажется. Давайте. Можете. Мы сейчас обсуждаем только внутри, нас никто не слышит.
Но при анализе подгрупп, когда анализировалась группа больных с митральной регургитацией третьей степени, эффект хирургического интервенционного вмешательства был лучше. Может быть, это связано с неправильно выбранной популяцией для анализа?
Тоже очень хороший вопрос. То есть чем тяжелее степень митральной регургитации, тем эффективнее будет вмешательство. Ну, в данном случае митроклип, это может быть, да. То есть такой вопрос, поскольку были пациенты, критерием включения были митральная регургитация 2+, и так далее. Но у пациентов с третьей и большей степенью митральной регургитации результаты вмешательства были лучше. И вот можем ли мы сказать, что здесь...
Поэтому они взяли, наверное, вторую степень регургитации.
Я думаю, да. Так же, как пытаются ТАВИ делать у пациентов низкого хирургического риска и так далее.
Видимо, так. И, конечно, нужен субанализ в отношении степени. И мне кажется, что очень интересный трайл был связан с аспирином.
Вот сейчас мы к нему перейдем.
С одной стороны, да, с одной стороны,
много обсуждать этот вопрос.
На возникновение влияет, правда, 1,1%, не очень событие, да. И очень важно было бы интересно знать в отношении побочных эффектов, риск кровотечения.
Значит, у нас вопрос с аспирином. У нас было несколько исследований. В частности, Эва докладывала вот эти исследования Ascent и Arrive. И она показала, что использование аспирина в качестве первичной профилактики, с одной стороны, приводило к улучшению результатов, с другой стороны, это было уравновешено высоким количеством кровотечений. И поэтому общий вывод, что мы не должны использовать аспирин в качестве первичной профилактики, чем, собственно, и занимались. То есть мы не давали аспирин. И вот Евгений Владимирович задал. Мы задали этот вопрос про аспирин? Какой вопрос еще, Евгений Владимирович?
Побочных эффектов.
Какие побочные эффекты, кроме кровотечений, наверное? Да, потому что у части пациентов могут быть астма, могут быть какие-то другие, могут быть язвенные поражения желудочно-кишечного тракта. Вообще аспирин – это большая проблема, не сам по себе, а вот его назначение. Многие пациенты сами себе назначают аспирин, тем более он продается без рецептов и рекламируется активно по средствам массовой информации, и они не считают нужным сказать это врачам.
И мы думаем, что это такой безобидный препарат.
Да, и мы думаем, что это безобидный препарат. А потом мы им назначаем антикоагулянты, и когда мы задаем пациенту вопросы, что вы принимаете из препаратов, они называют гипотензивные препараты, статины, но аспирин они не считают каким-то особенным лекарством, они его не называют. А мы им назначаем антикоагулянты, допустим, пациентам с фибрилляцией предсердий. И потом получаем, конечно, очень большой риск кровотечений. Поэтому с аспирином все не так просто. И что о себе? Да, хорошо. Но они будут группировать эти вопросы. Ну и еще, кстати, не только аспирин. Многие наши пациенты принимают нестероидные противовоспалительные препараты. И аспирин, собственно, является одним из препаратов из этого класса, хотя мы используем его в маленькой дозе, потому что нестероидный эффект у него проявляется в дозе 500 мг и выше. И наши пациенты не говорят, что они принимают каждый вечер, скажем, ибупрофен или мелоксикам, или там, я не знаю, диклофенак. И это тоже проблема. Более того, для пациентов с ишемической болезнью сердца все нестероиды, мы знаем, являются антагонистами аспирина по действию на агрегацию тромбоцитов. Если пациенты и все нестероиды повышают смертность от ишемической болезни сердца. И поэтому они должны либо с осторожностью назначаться, либо вообще они противопоказаны при ИБС, поскольку они блокируют эффект аспирина на тромбоциты. Они сами, естественно, тоже снижают агрегацию тромбоцитов, но это эффект временный. Аспирин необратимо блокирует агрегацию тромбоцитов, поскольку он ацетилирует циклооксигеназу, этот эффект необратимый, в отличие от всех остальных нестероидов, которые связываются с циклооксигеназой, потом выходят из нее, и она опять начинает синтезировать тромбоксана-2. Поэтому аспирин такая большая-большая проблема. Я согласен с Евгением Владимировичем. Это мой Еще будут вопросы по аспирину или нет?
Можно еще задать два вопроса?
Давайте, сколько угодно.
Касается исследования с тикогрелором.
Да.
Исследование показало,
Вот,
что монотерапия тикогрелором не хуже двойной дезагрегантной терапии. Но что смущает в этой ситуации? Мы достигаем такого же клинического эффекта, но не снижаем риски кровотечений. Вот как эксперты трактуют вот этот факт?
Очень хороший вопрос. То есть при назначении... Сформулируйте его, ему сейчас быстренько на английский его... Они по-русски еще не умеют.
Извините.
Да. Значит, в исследовании Global Leaders...
Да, в исследовании каком?
Global Leaders называлось. Тикогрелор, да.
Да. Монотерапия тикогрелором в течение 12 месяцев показала не меньшую эффективность, чем двойная дезагрегантная терапия, но при этом сохранялся достаточно подобный риск кровотечений.
И вопрос?
Имеются ли преимущества в плане снижения риска кровотечения?
Имеются ли преимущества в назначении тикогрелора? Да. В плане... Вообще, конечно, AstraZeneca старается сейчас тикогрелор максимально распространить. Мне этот препарат очень нравится. Но вот Марко сказал очень интересную вещь, я с ним согласен. И Роксана, по-моему, его поддержала. Она заключается в том, что, с одной стороны, у нас кардиология становится все более и более сложной дисциплиной, а с другой стороны, мы стараемся ее как можно упростить. Вот то же самое назначение, допустим, оральных антибиотиков вместо внутривенных антибиотиков. Безусловно, участие пациентов – это выход, это хороший выход, поскольку это лучшее качество жизни, не обязательно держать пациента в клинике, а потом пациент с постоянным, вероятнее всего, центральным катетером, кроме того, что он получает антибиотики, он еще и получает более высокий риск инфекции, риск каких-то тромбозов на катетерах и так далее. Так что, конечно, вот идея этого исследования, наверное, в облегчении лечения пациентов. Причем там были пациенты с острым коронарным синдромом и со стабильной ишемической болезнью сердца, когда один препарат, тикогрелор, мы знаем, мощный ингибитор P2V12 рецепторов, может заменить двойную антитромбоцитарную терапию. Вот этот вопрос, я думаю, мы им отправим. Очень важный вопрос. У меня был восклицательный знак, я его пропустил. Спасибо. Еще по аспирину еще какие будут вопросы? Молодежь, мы должны засыпать их вопросами. Мне Евгений Владимирович сказал, пока 98 вопросов не будет задано, никто не выйдет из аудитории. Это надо понимать.
Компьютерной томографии мы привыкли,
Давайте,
что
да.
пациенты умеренного и высокого риска,
сейчас я найду, что я писал
информативность компьютерной томографии низкая. И это,
сейчас,
не
я найду, где я про это писал. Вот,
память,
да.
3 класс рекомендаций. То есть не
еще раз,
у пациентов промежуточного и высокого риска информативность компьютерной коронарографии очень низкая.
Да.
И какую цель преследовали исследователи, применяя компьютерную томографию у больных со стабильной стенокардией? Они дополнительно считали и индекс Агатсона.
Да, там, безусловно, был коронарный кальций, да. И плюс они, я думаю, считали процент стеноза, то есть какие были показания к выполнению CTA у пациентов в исследовании.
Может быть, это какая-то особый аппарат, компьютерный томограф, который давал
Нет, это обычный
изображение.
Компьютерный томограф, да. Тем более, я знаю людей, которые участвовали в этом исследовании. Сам Штефан Ахенбах, он вообще из мира компьютерной томографии, вот он с компанией Siemens сотрудничает много лет, и он эксперт. Там были обычные томографы и обычная компьютерная КТ-ангиография, мультиспиральная КТ. Но в этой связи у меня тоже немало вопросов, хоть они показали 41% снижение относительного риска, но, как Штефан сказал, на самом деле он с 1%, там, в абсолютных цифрах это 1 или пару процентов, но они очень много обсуждали, я думаю, этот вопрос, если вы согласитесь, мы им зададим. Они говорили, что у пациентов, которые имели КТ-ангиографию, в 10 раз больше было, на 10% было больше назначения статинов. И мне кажется, что когда приходит пациент, и мы делаем ему нагрузочный тест, и тест положительный, мы понимаем, что у него есть коронарные стенозы. Но когда мы делаем КТ-ангиографию, мы видим эти стенозы. И нам становится немножко страшнее, особенно когда мы видим кальций и так далее. И мы с большей вероятностью назначаем им статины. Но есть очень важный вопрос. который не затрагивался. Можно назначить 10 мг статина, а можно назначить 80 мг статина. И, возможно, когда мы видим много кальция и тяжелые стенозы коронарных артерий, у нас... Когда мы видим вот эти ужасные стенозы, мы назначаем оптимальную дозу статинов. Потому что доза препаратов, она имеет значение. Да? Так же, как мы не назначаем рекомендованно 50 мг карвидилола при ХСН, а назначаем там 6-125 2 раза в день, что не является никаким прогностическим, значит, не приводит к прогностическому улучшению. Точно так же назначение просто 10 или 20 мг аторва или розового статина у пациента с ИБС не приводит к улучшению результатов. А возможно, когда врач видит стенозы на КТ-ангиографии, он назначает уже 40 или 80 мг там, аторвастатина или 40 мг розового статина. Я бы задал вопрос, может быть, у пациентов, у которых визуализируются стенозы, назначались большие дозы статинов, поскольку доза имеет значение не просто назначение препарата. Хорошо. Why the statin dose is different in patients? Терапия была, в принципе, одинаковая. Более того, они получали аспирин. Как бы... про дозы. Да, были разницы, вот кроме того, что просто назначали статины, какие статины и в каких дозах? Так, Евгений Владимирович? Да. Это очень важно. У пациента в исследовании Скотт-Харт. Да, Скотт-Харт. Скотт-Харт. Вот. И что интересно... Да, и они получали аспирин. Еще у нас было очень интересное обсуждение по поводу аритмий, конечно же. Это мы обсудили, я думаю, это мы тоже обсудили. По поводу аритмий. Пациенты с фибрилляцией предсердий, которым делали аблацию АВ-соединения, имплантировали бивентрикулярный кардиостимулятор. Вот, с узким комплексом КРС, хотя мы знаем, что имплантация CRT, она происходит при широком комплексе КРС или там, при блокаде левой ножки пучка Гисса. Это раз. И у пациентов с фракцией выброса меньше 30% была особенно большая разница, особенно большое преимущество стратегии интервенционной. Я бы задал вопрос, например, у кого есть вопросы по этому? Евгений Владимирович, у вас есть вопросы? Давайте. Да, и мы зададим вопрос.
Объяснил, что, как правило, после аблации возникает ситуация по типу блокады левой ножки. Да? И это оправдана такая превентивная имплантация ресинхронизирующего устройства.
У меня выключен просто телефон. Сейчас я его включу тогда. Потому что действительно, вот это немножко смущает, имплантация CRT у пациентов с узким КРС, хотя есть исследования, где именно таких пациентов тоже пытались ресинхронизировать, и в некоторых исследованиях довольно успешно. Но тут возникает еще второй вопрос. У пациента с фракцией выброса менее 30% мы обязательно должны имплантировать хотя бы кардиовертер-дефибриллятор. Так, Сейчас. Пока не получил от вас ничего, Александра Олеговна. Ждем. Нет. Давайте. Вот. Означил ли пероральный прием антибиотиков, я так думаю, возможность перехода на амбулаторное лечение? Как гарантировать приверженность? Очень важный вопрос. То есть у пациента в исследовании по эндокардиту, да, они мониторировали в крови, но да. Да, вопрос в том, что в реальной клинической практике назначение препаратов и высокоэффективные антибиотики в больших дозах, а мы только такие используем при эндокардите, они довольно плохо переносятся. Вероятнее всего, да. Хотя мы знаем, что есть определенная доля эндокардитов, скажем, у внутривенных наркоманов или у пациентов... С низкой социальной ответственностью, да, как мы знаем. Да, и вопрос по диссекции сейчас задам. Это очень важная тема. Так вот, по исследованию с аблацией и имплантацией CRT мы задаем вопрос или нет? Или мы всем довольны в этом исследовании? Всем довольны? Да? И мы часто ее делаем. Но вот я скажу из своей практики, то часто я делал аблацию и ставил однокамерный стимулятор. Давайте вот мы зададим вопрос. Вам тоже приходят, да? Так.
Можно задать вопросы
Давайте,
по этому
конечно,
исследованию?
конечно.
Какая была средняя частота на фоне постоянной формы фибрилляции?
Еще раз, если можно.
То есть это была тахисистолическая фибрилляция предсердий. Какая там была средняя частота в этом исследовании на фоне фибрилляции?
Очень хороший вопрос. Давайте мы его зададим. В исследовании АПАФ-CRT какая была средняя частота? Я думаю, что тахисистолическая, которую невозможно было уредить бета-блокаторами, либо они были... Там любая была?
Состоит в том, что, насколько я понимаю, что при узком комплексе постоянной фибрилляции лучше...
А мы их спросим.
Да.
Давайте мы их спросим. Чем больше вопросов, тем лучше. В исследовании АПАФ-CRT были различия исходов в зависимости от средней частоты сердечного ритма. Да? Вот так. Очень хорошо. Cabana, конечно, которая произвела фурор, и абсолютно точно сказала Роксана, что если мы его сравним с интервенционными другими исследованиями, он очень напоминает исследование Courage, в котором не было разницы по выживаемости у пациентов на медикаментозной и интервенционной стратегиях лечения стабильной ишемической болезни сердца. Я бы хотел сказать, что во всех этих исследованиях и с митральным клапаном, и с стентированием, и вот Cabana, очень важный момент. И это написано во всех рекомендациях, что мы должны рассматривать интервенцию, когда пациент находится на уже неэффективной, но оптимальной медикаментозной терапии. Как происходит в реальной жизни? Пациенту с ишемической болезнью сердца дают аспирин, чуть-чуть бета-блокатора, нитрат, статин, у него остается стенокардия, он идет на стентирование или на АКШ. У пациента 2-3 пароксизма фибрилляции предсердий, ему говорят, что надо рассматривать аблацию и так далее. То есть вопрос в том, должны ли мы добиваться все-таки оптимальной медикаментозной терапии, или мы должны эти вмешательства рассматривать раньше, поскольку и то, и другое вроде бы улучшает качество жизни, хотя недавно было исследование орбита, я думаю, вы слышали, в котором показали, что на самом деле черезкожные вмешательства не улучшают качество жизни, что было основой вообще всех этих вмешательств. Мы давно знаем, что они меняют смертность, но все говорили, они хотя бы качество жизни улучшают. В орбите показали, что по сравнению с оптимальной медикаментозной терапией коронарное стентирование и качество жизни тоже не особенно улучшает. Особенно если добавлять новые препараты, ранолазин и так далее. И вот мне кажется, что с этой точки зрения вот именно концепция оптимальной медикаментозной терапии очень важна. Какие будут комментарии, я бы хотел услышать. Нет комментариев. Давайте мы зададим им такой вопрос. Насколько все исследования Cabana, Courage и так Cabana, вот так оно пишется, подчеркивают важность и исследования Mitra FR подчеркивают необходимость оптимальной достижения, она называется Guidelines Recommended Optimal Medical Treatments. То есть вот насколько это, мне кажется, это важно, чтобы мы пациентов лечили оптимально медикаментозно. Это касается и артериальной гипертензии, и сердечной недостаточности. Я часто, вот и сегодня тоже привожу этот пример. Пациентам ХСН мы должны дать бета-блокатор. Это может быть карвидилол, это может быть метопролол, это может быть бисопролол, но мы даем совсем чуть-чуть. Потому что если мы дадим 50 мг пациенту с фракцией 35 и давлением 100 на 50, он умрет. И мы должны начать с одной 18-й таблетки, потихоньку это титровать, это долгий и нудный процесс. Но если мы не дойдем до 50 мг, то мы не дали ту дозу, которая снижает смертность в исследовании определенном. Да? Но только это и называется оптимальной медикаментозной терапией. И мы не можем сравнить смертность у пациентов, которые получают чуть-чуть бета-блокаторов, чуть-чуть ингибиторов АПФ или сортанов. И мне кажется, вот это достижение оптимальной медикаментозной терапии тоже важная концепция. Еще у нас очень интересное, мне кажется, исследование по цифровым технологиям, когда пациенты с помощью вот этого пальцевого исследования и камеры телефона посылали свои данные, и у части из них выявлялась фибрилляция предсердий. Вот что вы думаете по этому поводу? Тут очень противоречивые, мне кажется, данные, потому что вот мы выявляем этих пациентов, и Джон Кам сказал, что многие из этих пациентов были молодые. Если бы там были пациенты старше 60 лет, то вероятность выявления была бы гораздо больше. Но если это молодые здоровые пациенты, у которых мы выявляли пароксизм фибрилляции предсердий, И, вероятнее всего, количество баллов по шкале Чацваск у них будет 0, независимо от того, это мужчины или женщины. То есть мы не вмешиваемся, мы не назначаем им антикоагулянты. Тогда вопрос, зачем нам выявлять эту фибрилляцию предсердий?
Подход очень хороший, и с точки зрения выявления скрытых нарушений ритма он оправдан. Другое дело, что вопрос чувствительности, об этом они говорили,
да.
не 100%. И мы можем пропускать тех больных, у которых есть нарушение ритма, которые не детектировались, тем самым больные не получали антикоагулянтную терапию. Поэтому, поддерживая этот подход, мы все-таки полагаем, что мы должны использовать более эффективные какие-то девайсы для контроля нарушений ритма, они есть. Тот же самый смартфон вместе с другими датчиками.
Да. То есть,
и еще лучше, конечно, это все использовать не у здоровых, а у больных, наверное, хотя бы среднего промежуточного риска, невысокого, с точки зрения не только нарушения ритма, и там, где есть возможность отследить сегмент СТ.
То есть у нас получается два вопроса.
Хотя бы в одном отведении.
Возможно ли использование более точных методов определения сердечного ритма? Что? Чувствительность была небольшая у них. Они из огромного количества пациентов выявились. Да.
Или такой распространенности?
Вот это хороший вопрос. Небольшое количество выявленных фибрилляций предсердий в исследованиях Digital AF. Это было следствием маленькой распространенности или недостаточной чувствительности? Это и могут ли другие устройства с большей чувствительностью? Да. Как они относятся к другим устройствам по детекции нарушения ритма? Да. И многие из них, например, одно из них разрешено FDA, допустим, вот эта наклейка на заднюю панель. Да. И второй вопрос. Добавление хотя бы одного канала ЭКГ с точки зрения определения СТ-сегмента. Может ли это как-то улучшить, да, Евгений Владимирович, может ли это как-то улучшить исходы у этих пациентов, поскольку мы знаем, внедрение тотальной маммографии резко повышает выявляемость рака молочной железы, но смертность не снижается. Да, но смертность не снижается. Точно так же, как тотальное внедрение измерения ПСА у мужчин резко повысило выявляемость рака предстательной железы, особенно у пожилых пациентов, но тем не менее смертность не снизилась. И сегодня мы либо после 75 лет не измеряем ПСА вообще, нас он не интересует, а если измеряем и находим высоким, мы даже не делаем часто биопсию предстательной железы или не выполняем какое-то лечение, там, хирургическое, простатэктомию или медикаментозную хирургическую кастрацию или назначение каких-то там брахитерапий и так далее. Поэтому, мне кажется, тоже важный вопрос. Это мы обсудили. У нас, конечно, остались исследования, которые докладывал Марко. Очень интересные пациенты с кардиогенным шоком. Это самая тяжелая группа пациентов. И вот на это много раз останавливалось внимание. Они умирают. 56% смертность в течение 30 дней. Несмотря на то, что эти пациенты лечились в лучших клиниках. И вот Хенрих Теле, который докладывал эти данные, он сам директор огромной клиники, замечательной совершенно в Германии. И он говорил, мы с ним близко знакомы, что эти пациенты часто умирают, не успевают поступить в больницы. И мы знаем, что у пациентов с кардиогенным шоком было нейтральное исследование шок intra-aortic balloon pumping, и сегодня не рекомендовано использование внутриартальной баллонной контрпульсации. С другой стороны, вот вопрос, на который пытались ответить исследователи, должны ли мы реваскуляризировать инфаркт-ответственную артерию при многососудистом поражении, или мы должны реваскуляризировать все артерии, как мы стараемся делать при обычном остром коронарном синдроме, не сопровождающемся кардиогенным шоком. Вот какие будут вопросы? Это очень важная тема, таких пациентов очень мало. И это самая тяжелая группа пациентов, но они бывают. И вот мы должны понимать, что с ними делать, и какого-то общего понимания нету. Марко говорил о том, что мы можем использовать и баллоны, или какие-то искусственные устройства вспомогательного кровообращения. И я бы, наверное, задал вопрос, вместо искусственного левого желудочка, можем ли мы использовать ЭКМО, который довольно легко устанавливается у таких пациентов. In patient's culprit shock. Is ECMO a good option? Вот. Какие еще будут соображения по этому поводу? Вот. У вас бывают пациенты с кардиогенным шоком или они редкие? Часто? А это пожилые пациенты, это диабетики или какие-то пациенты?
Как правило, это пожилые мужчины с множественной патологией.
И какая у вас стратегия?
Стратегия, сейчас мы переходим на ЭКМО.
На ЭКМО?
Да.
Я полностью согласен.
То есть вначале инотропная терапия, и когда мы видим, что в течение часов принимается решение о установке ЭКМО.
Да, потому что...
Надо отправлять вопросы, 8 минут осталось до включения.
Да, сейчас мы зададим вопросы. И, конечно, очень-очень важная тема по СКАД. Поскольку СКАД, мы знаем, что так называли наши ракеты, но СКАД это еще и спонтанная диссекция коронарных артерий. И на самом деле СКАД это еще и спонтанная диссекция сонных артерий. И вот второе состояние, это самая частая причина инсульта у женщин моложе 50 лет, спонтанная диссекция сонных артерий. В данном случае рассматривалась спонтанная диссекция коронарных артерий, и там были в основном девушки, средний возраст 52 года, и на этом было заострено внимание. Мы часто думаем, что это женщины 40 лет и моложе. Маркус сказал, что это беременность или перипортальный период, не совсем так. Там чаще перипортальная кардиомиопатия, которая не связана с коронарными проблемами, там прямое повреждение миокарда. Но мне кажется, что это тоже очень важная проблема. Что мы думаем по этому поводу?
Все-таки терапии, принимали ли они гормональные препараты какие-то? ГЗТ был или не
Пациенты
было?
в исследовании Canadian SCAD.
Потому что явно это эндотелиальная дисфункция.
Получали ли пациентки какой-то гормон заместительный, вы имеете в виду? Гормон, поскольку они были постменопаузальны?
52.
Да, 52 года. То есть какая частота приема гормон заместительной hormone replacement postmenopausal therapy? Вот. Тем не менее, они показали, что смертность 0,1%. Но у них было довольно много инсультов. И, возможно, это общая патология сосудистой стенки, которая проявляется и в коронарных артериях, и в сонных артериях. Потому что 30% из этих девушек имели стеми, то есть не просто ОКС, а именно стеми, и только 0,1% смертности. Самое интересное, тут, мне кажется, надо остановиться на двух моментах. Первое, они говорили, что большинство пациентов получали консервативную терапию. А что такое консервативная терапия? То есть там даже не было тромболизиса, получается, да? Какая консервативная терапия при стеме? Была ли там тромбоэкстракция или была ли тромболитическая терапия? То есть это, я думаю, что тромболиз это не консервативная терапия, это уже интервенция, это реперфузия. А? То есть просто их лечили консервативно. Но это реперфузия, она не интервенционная, да. А давайте мы спросим, какая была частота тромболитической терапии в исследовании Canadian SCAD и какая еще консервативная терапия у них рассматривалась. И второе, мы видели картинки, полученные с помощью оптической когерентной томографии. То есть этот диагноз невозможно поставить, не выполнив оптическую когерентную томографию. Обычная коронарография покажет окклюзию, тромботическую окклюзию коронарной артерии. И только после, скажем, реканализации, тромбоаспирации или тромболизиса мы можем ввести датчик для УКТ и посмотреть, что там действительно диссекция интимы. И вот можно ли поставить этот диагноз, не выполнив оптическую когерентную томографию пациента? Мне кажется, это тоже важный вопрос. Потому что очень часто делают тромбоаспирацию, либо тромболизис, и потом этот отслоившийся участок интимы прижимают к стенке баллоном, ждут несколько десятков секунд, он быстро прилипает обратно, вытаскивает баллон, и все на этом заканчивается. Заканчивается без установки стентов. И вот считается ли это консервативной терапией или нет, тоже мне непонятно. То есть, что они считали консервативной терапией? Коллеги, мне кажется, мы в таком экспресс-формате обсудили довольно много тем. Большое всем спасибо. И нашим коллегам больше не было из России вопросов? Еще 10 минут у нас. Давайте тогда продолжим обсуждение. Вот по диссекциям есть вопросы? Я абсолютно с вами согласен, Евгений Владимирович. Эта проблема намного шире, и она часто остается нераспознанной. Часто нераспознанной. Как часто мы можем, вот вопросы, как часто мы можем рассматривать наличие СКАТ у пациенток с ОК, in female patients with SCAT and angiographically normal coronary? Конечно, когда мы видим окклюзию передней артерии и абсолютно нормальную правую и огибающую, тут возникают вопросы. А их лечат стандартно, поскольку им не делают ОКТ. Поэтому, мне кажется, важно, нужно ли ОКТ делать в таком случае, как обязательный метод исследования. Да, да. Еще раз, как? How often can we see SCAT in female patients with STEMI and angiographically normal coronary arteries? Вопрос такой. Здравствуйте, коллеги. Начали встречаться пациенты в стационаре после проведенного РЧА по поводу ФП, коморбидные. Почему-то аритмологи назначают ПОАК, пероральный, наверное, только на 3 месяца с дальнейшим прекращением. Подскажите, насколько это правильно? Это вопрос очень важный. И Джон это отметил. Вот в исследовании, допустим, Cabana, где он показал значительное улучшение качества жизни после радиочастотной аблации. Но тут вопрос в чем? Часто, к сожалению, аблация выполняется для того, чтобы пациенту не давать потом пероральные антикоагулянты. Но мы знаем, что, во-первых, эти пациенты имеют короткие непродолжительные эпизоды фибрилляции предсердий, которые они перестают чувствовать, поскольку они из тахиформы могут перейти в нормоформу. Вот. И, во-вторых, все равно у них происходят рецидивы. Эти пациенты не принимают оральные антикоагулянтные препараты. Я бы задал такой вопрос, вот в продолжении того, что наша коллега спросила. Должны ли мы после исследования Cabana назначать оральные антикоагулянты независимо от выбранной тактики лечения, интервенция либо консервативная терапия? Найдут ли отражение в дальнейших рекомендациях результаты исследования ARIVE о нецелесообразности назначения аспирина с профилактической целью пациентам умеренной категории риска? Это то, что Евгений Владимирович говорил. В нашей стране поголовное назначение аспирина без оценки рисков кровотечения является серьезной проблемой. Тем более мы включаем телевизор и показывают, что кардиомагнил спасает жизни, там новый какой-то аспирин стали рекламировать. Непонятно почему. Ну и все пациенты мне рассказывают, что в Америке все после 50 пьют аспирин, и мы тоже их пьем. И еще проблема в том, что пациенты часто не говорят нам о том, что они принимают аспирин. Многие не знают, что это аспирин. Они пьют кардиомагнил, пациент может не понимать, что кардиомагнил – это ацетилсалициловая кислота. Давайте мы им зададим вопрос. How often we see self... Сейчас я себе даже записал этот вопрос. Сейчас, где у меня первая? Вот первая. Ладно, чтобы не терять времени. Self-administration of aspirin. How often do you see self-administration? У пациента 54 года, спустя этот вопрос уже был. Сколько всего можно повторно делать ФРЧА? Мы знаем, что нет такого человека, которому нельзя сделать ФРЧА, даже без фибрилляции предсердий. Так что нет такого человека, которому нельзя было поставить стенд, к сожалению. И я думаю, что то, что мы делаем в рамках Российского кардиологического общества, очень важно, чтобы мы все-таки интервенции как-то привлекали к нам. У нас есть, в Европе все очень просто, у них есть Европейское кардиологическое общество, и под этим общим зонтиком Ассоциация нарушений ритма, Ассоциация частокознных вмешательств, Ассоциация сердечной недостаточности, визуализации и так далее, и так далее. У нас в России ситуация немножко другая, и поэтому наши коллеги, скажем так, которые занимаются интервенциями, и при этом не все из них являются кардиологами, так мягко говоря, они не находятся в тесном контакте с РКО. И мне кажется, все-таки задача РКО и в том, что Евгений Владимирович... Да, я думаю, это должна быть...
Я теперь знаю, кто у нас возглавит это направление.
Да, вот. Но это не вопрос, конечно, нашим коллегам. Еще 5 минут у нас. Еще мы можем задать 15 вопросов. Какие еще вопросы? Может быть, просто по Конгрессу. Давайте мы выйдем немножко за рамки этого. У нас был тикогрелор. Очень важный вопрос, который не затронули, что вот в последнее время довольно большое количество исследований, они так называемые negative trials, то есть делают исследование, оно получается нейтральным.
Александром Олеговичем говорили о том, что уже то, что тикогрелор равен, не хуже
Двойной
двойной терапии, это уже хорошо.
Я согласен.
Почему мы должны говорить, что обязательно должен быть лучше?
И это проще. Да. Это проще, с одной стороны. С другой стороны, было исследование STEAM совершенно недавно доложено, где использовали тикагрелор вместе с тромболитической терапией. До недавнего времени мы не могли, и формально по рекомендациям мы сегодня не можем, кроме клопидогреля, использовать другой ингибитор P2 и 12 рецепторов вместе с тромболитической терапией, независимо от того, это фибрин специфический, фибрин неспецифический агент. Но было показано, что тикагрелор не хуже, чем клопидогрель.
Основание.
Я абсолютно с вами согласен. Я даже себе записал вопрос. Вот этот negative trial, это все-таки trial, который отвечает на вопрос. И поэтому можем ли мы считать, что нейтральный результат является не менее важным, чем положительный результат? Точно так же, как новые оральные антикоагулянты показали то, что они не хуже, чем варфарин во всех исследованиях Релай, Аристотель, РОК-ЭТФ. Но формально мы не можем сегодня говорить с точки зрения этих больших исследований, что ревароксабан, апиксабан, эдоксабан или дабигатран лучше, чем варфарин, поскольку исследования изначально не были так запланированы. И это получились, скажем так, негативные исследования, в том смысле, что они не показали преимущества, потому что они не были запланированы как исследования, которые должны были показать преимущества этих новых, они уже не новые, оральных антикоагулянтов. Но, тем не менее, они оказались не хуже варфарина по снижению эмболических инсультов, но лучше варфарина либо по снижению количества кровотечений, либо по снижению количества, либо по снижению смертности, как у дабигатрана 150 мг и у апиксабана. Поэтому вот эти negative trials, мне кажется, тоже очень важны. По клапанам, конечно, было много исследований. Задавайте вопросы, я вас очень прошу. А то я уже запутался в своих листочках немножко. Евгений Владимирович, а как часто вы видите диссекции коронарных артерий или сонных артерий? Инсульты к вам тоже поступают или нет?
Не так часто, но если она случается, это не является для нас чем-то необычным. То есть мы уже к этому готовы.
Не является необычным.
Да, не является необычным. Это, не часто, но это обычная, в общем, ситуация. И наши специалисты, я никогда не забуду, когда у нас был больной, уже с многими факторами риска, относительно высокого риска, который мне говорит: слушайте, у него диабет, у него гипертензия, у него ишемическая болезнь, он был стентирован. И он мне говорит: мы сделали стресс-эхо, и была пограничная ситуация. И он говорит: вы знаете, а все-таки внутренний голос говорит мне: давайте сделаем. Сделали, а там отслойка интимы. Поэтому...
Которая еще не успела привести.
Не успела, да.
То есть вы
да, в общем, да.
Да. Очень интересно, и я думаю, что мы можем задать такой вопрос: а что подразумевается интервенционным лечением спонтанной диссекции коронарной артерии? Это стентирование, это баллон, это тромбоаспирация или что? Ну вот, уважаемые коллеги, 1 минута осталась у нас до старта обсуждения. Мне кажется, мы задали... Давайте, да, и вопрос зададим такой, question to Mark. Да, какая средняя частота СКАТ у пациентов с ОКС? Да, наверное, так. Потому что на самом деле довольно много мужчин таких. Мы знаем на фоне... Очень часто это связывается с артериальной гипертензией, с гипертоническими кризами. Мы должны помнить, что артериальное давление высокое на руке не передается на коронарные артерии. В коронарных артериях кровоток диастолический. Нас больше волнует диастолическая гипертензия. И если... Давайте мы спросим вопрос: есть ли связь между диастолической гипертензией и частотой СКАТа? Поскольку коронарная... Как часто у пациентов с СТЭМи задавайте. Мы можем продолжать задавать вопросы по мере того, как они будут отвечать на наши вопросы. Да. Звук. Включите здесь звук.
Concerning the topics that we have discussed, and in fact we have been discussing among ourselves because there's so much that can be and needs to be covered about the trials that we talked about. And why don't we start at the very beginning? The first trial we mentioned when we were live a short while ago was the POET trial. And we had questions coming in concerning this trial in the treatment of endocarditis. Romania, for example, asked whether it is a clinical option to do oral-only treatment of endocarditis. And I know you know a lot about the trial. I would like to clarify right here. This was not about completely oral versus completely IV treatment. All patients had 10 days of IV treatment to begin with. And then if they had satisfactory control of infectious symptoms, no temperature, CRP going down, then they were randomized to receive either oral treatment or to receive further IV antibiotics.
And the transesophageal echo before they
yes. And the other question coming in from Russia is how was compliance assured in this trial? And this is not something you can simply, give a packet of pills to your patients and then make them go home. These patients came back to the outpatient clinic, and they came back every 2 or 3 days. They had antibiotic levels checked. They had infectious symptoms and lab values checked. So this was close monitoring going on in the context of this randomized trial, which does not mean that in the future we will not be following such a scheme, maybe a little bit more liberally, but at the moment we have to be aware of the fact that this is not just giving them a packet of pills and sending them home.
Compliance is an issue, though, with oral.
Any trial result that we see in a randomized trial always has to be taken with a precaution whether this can be translated to real life, and compliance is just one of the issues.
And they didn't include endocarditis related to drug addiction and so on. So it had to be patients who would be compliant.
75% of patients who were screened were excluded. We have to remember that. There was a question also coming from Montenegro, I think, whether there was any difference in microorganisms between the two groups, but there was not. I mean, they looked at the microorganisms. It was mainly Staphylococci and Streptococci as usual, and the distribution was exactly equal. And there was also a question, what was the recommended scheme for oral treatment of Staphylococci? That's a very specific question that came in, and it was rifampicin and linezolid, or rifampicin and amoxicillin. So those were the typical combinations that were used to answer these very specific questions. Another trial, well, actually all of the trial did raise lots of questions, but another trial that we also discussed rather intensively, on camera and off camera, I might say, was the Scott Hart trial. And one question, for example, that came in is an interesting question. Many patients were treated by statins. Was there a target LDL level that was prescribed to these patients within the trial?
It wasn't part of the trial. It was the part of the, and as you mentioned, Roxana, they gave the information to the GP or whoever was caring for the patient, and they decided what to do. Of course, they had the information on the CG angio, or in the group that didn't have a CG angio, they just had the information on what their estimated risk was.
Exactly. So information about the findings was given, but no specific treatment was part of the study protocol. Another trial,
That's a really good question, though, right? Because I think if you imagine that the arm that, and we won't know this because I don't think it's in the paper what the target was and what they achieved. The arm that was in the CT angiography, that the patient has coronary disease. You're going to really drive that LDL really down, as opposed to the low-risk patient who may or may not have coronary disease. So I think it's a very good question.
Yeah. It would be nice to know whether the control group was evidence-based prevention also, whether they followed the recommendations for that. And still, we don't know why didn't they find the same in the PROMISE trial. Was that because the control group had, or the functional assessment group had more intensive follow-up by cardiologists?
I think there are a number of differences between the Scott Hart and the PROMISE trial. The PROMISE trial also randomized patients with suspected coronary disease. In the PROMISE trial, they received either CT or functional testing, not as in Scott Hart, functional testing for everybody and then CT on top of it in half of the patients. The functional testing was imaging, was mainly scintigraphy, myocardial perfusion scanning in the PROMISE, and the pre-test likelihood was a lot lower.
Yeah,
And we're talking very low risk patients, and it's going to be difficult to show a difference in very low risk patients. Plus, they were not followed long. They've got hard results after 5 years. Congratulations to the authors for performing a 5-year trial and not losing any patients. So there are a number of differences in these trials. Somebody raised the issue of radiation risk. No, we're potentially doing benefit to the patients, but we're giving radiation. Eva, what are your thoughts on this?
Well, we certainly should be a little careful with the younger women in particular. The probability of coronary artery has to be assessed, of course, and if it's low, I mean, I don't think CT angio is the imaging of choice in the younger women if they have symptoms. I mean, the likelihood of obstructive coronary artery disease is very low.
Obviously, and when the radiation risk is high in a young patient and the potential, likelihood of coronary disease is very low, then it probably makes less sense than in somebody who is at somewhat higher risk and higher
and in
age.
young people who have a long life ahead of them where they're going to be subjected to a lot of other radiation, I mean, you have to be careful with that.
But once again, I'm the protagonist for cardiac CT. I admit this as a bias. There was another trial presented at the ESC Congress, which is Protection 4. It was a registry that looked at the dose of coronary CTA and how it developed in the 10 years between 2007 and 2017, and it went down by 80%. The dose now is 80% lower than it was 10 years ago. The
precision has increased despite lowering the dose, which is pretty significant.
So it's a lot of detail to discuss. Dose is important, but we're making good leeway in reducing dose in coronary CT. But something that needs to be discussed. Another technology is FFRCT. There was quite a bit on FFRCT at this ESC Congress. Riga from Lithuania is asking, what about FFRCT in the Scott Hart trial? Was it used?
I don't think so.
It was not.
No, it was not.
It was not used in the trial.
It's very interesting technology, though, and I still think it needs to be validated. But imagine, I know that there was Patrick Soroy's presented some data on this at
multi-vessel FFRCT.
and using FFRCT as a way to kind of risk stratify patients, and that you can do a better, more precise way of risk stratifying and improving outcomes on the patients. It's a technology that's worth thinking about, and if we are going to use CT, wouldn't it be nice to actually have a functional test right along with it?
Ischemia. Maybe it's two different components.
Is the ultimate goal
Ischemia
to try to combine anatomical information with physiological information.
But that's what the Scott Hart is questioning. I mean,
but ischemia would tell you who to send to revascularization, and the plaque imaging would tell you who needs a balance. But we're not really speculating, right? We're not really,
it
very
needs
much
to be
based on
validated.
facts.
There's a lot more work to be
Let's
done.
go back to facts. Ascend and Arrive, our primary prevention trials, sparked lots and lots of questions. And of course, you can feel from the questions coming in that people liked or would like to give aspirin in primary prevention. And one question is there a bleeding score that we could potentially use to filter out those patients who are endangered by bleeding?
Not that I'm aware of.
Yeah. Nobody knows if any such
I wish
score.
the one I developed would work. I have a couple
And
of
also,
them,
of course, there's a
but I
question of
don't
getting
think so. I
getting a
don't think we don't
PPI
know.
at the same time, but we don't know what are the long-term consequences of that lifelong aspirin and PPI.
This was enteric-coated aspirin that was given. Do you think this might have made a difference, that resorption is less, or any other effect of enteric-coated? Can we simply apply this to any aspirin?
Bioavailability is a little lower, so it would be, I mean, if it's not enteric-coated, it can be 75 milligrams.
I mean, they were efficacious because people were bleeding.
Yes.
So,
Yes, exactly.
That's the
There's more
test, yes.
bleeding.
Our colleagues from Russia are asking, are there any negative comments, effects of aspirin except the bleeding risk? Is there anything else that needs to be taken into consideration?
Well, we thought there might be a positive effect on gastrointestinal cancer. That hasn't been confirmed in the ASCENT trial.
It's interesting, though, because we saw some data, I think, from COMPASS, right? That the bleeding associated with anticoagulation, in this case, helps you identify cancer.
Identify them,
But that's an old concept. We
like
call it the Warfarin stress test. in the past.
But whether that also leads to improved outcome, we don't know. Finding them a bit sooner, meaning you can treat them, we don't know. But they said they were going to.
It was interesting data coming from COMPASS that 10% of bleedings under anticoagulation lead to the diagnosis of cancer.
Yeah, actually, this was a very important information, and actually we should not if somebody is bleeding under anticoagulation, we should not simply say, okay, we stop, for example, but we should investigate both gastrointestinal, actually, and also genitourinary bleeding. Both needs to be investigated.
And any bleeding, not major, any bleeding. That was important.
Particularly with the NOACs, because they're in high concentration in all mucosa, so that they tend to provoke this more readily than.
So more for the NOACs than for
I think so, yes, because they're in high concentration in the gut as an active anticoagulant, and they're also excreted into the gut, not only absorbed from the gut.
It's an interesting point, very interesting point, so that's something that we all agree on, maybe a message that we can really emphasize once again. If people bleeding under anticoagulation or antithrombotic treatment, you should not just wave it away. You have to go after this because you have an option of finding the cancer earlier. Whether it really plays out to better prognosis, we don't know.
No, but you certainly shouldn't ignore it.
Shouldn't ignore it. More arrive questions, because aspirin is really moving the hearts of our colleagues out there.
As you say, we want to.
And the question is dose once again. Can you just give us some more insights that you have on the dose of aspirin in primary, secondary prevention? Because this is obviously a very important issue.
Well, I think they're regarded as we give 75 milligrams, 100 milligrams of entrecoded. I believe in the US you give 150 mainly.
No, we
no
use
less, right?
81 milligrams.
81 is used.
So no higher than that.
Low dose is best.
Low dose, but
which is somewhere between 75 and 100, right? In Europe, you use a lot of 100 milligrams. Often 100.
Often 100.
I mean, there was some discussion whether diabetic patient with established coronary disease may need a larger dose of aspirin, or maybe dose twice a day, because there is some increased turnover of platelets, but so far there is no clinical data supporting this.
It'll just cause twice as much bleeding, no?
Yeah.
Who knows?
John, there were lots of questions around your topic, obviously. Once again, arrhythmias are very frequent. Screening, identification, consequences of atrial fibrillation were reflected in many questions that came in. And let's talk about digital AF first. This is very modern, using smartphones. One question was it important whether the smartphone was hooked up via wireless or just the normal telephone net? Was there any technology difference there?
I think that in most cases it was just through a network. But the details of that are not apparent from the presentation. But it shouldn't make any difference, really. I mean, the whole detection is and the algorithm for understanding the rhythm are contained within the app, so it doesn't need to go into the cloud, for example, for any further analysis. But it's true that afterwards, when an irregular rhythm was detected, particularly if it was scrutinized and thought to be AF, those patients then would go to their doctors to have further investigation and further insight from the doctor before deciding whether any management was required.
That's another question that was asked actually more than once. Would you, John Cam, London, United Kingdom, would you establish the diagnosis of AF only based on the smartphone?
Well, I could if it was an ECG. For example, in the AliveCore device, you see the actual ECG, and it's very good ECG, and I think you can certainly diagnose atrial fibrillation from that. You can't diagnose all the other things you need from the 12-lead ECG to look for potential causes and consequences of the atrial fibrillation, but you can diagnose the atrial fibrillation from an ECG signal, From a plethysmographic signal, it's not quite as secure, but the investigators did do a lot of preparatory work in which they compared the ECG and the photoplethysmograph and found that they were very equivalent. So I would prefer to see the ECG, and I think that all the guidelines that we have on atrial fibrillation say that the diagnosis is dependent on an ECG tracing. And I don't think the photoplethysmograph alters that, but it gives you a very good clue.
The implications are major in terms just of treatment. You have to anticoagulate those patients, so
of course.
The diagnosis should be
yes, it should be absolutely certain. I completely agree.
In the study, they did, once they made the diagnosis with the plethysmograph, they verified it with a 12-lead ECG.
Well,
so in the 1.3%...
They asked the patient to go and see their doctor. And not all of them agreed, of course. There was a sizable proportion who bowed out at that stage and didn't follow it through. But for those who did, then the diagnosis was verified, yes.
Was it dependent on a specific smartphone? I don't want to mention any brand names here, but the sort of what comes to your mind?
I think the app is designed for both Android and iOS-based phones, so I think
it was
it's
not
widely applicable.
limited to a specific phone type?
I don't believe so, no.
More questions came in, obviously, about Cabana. Cabana has been giving us food for thought for a number of months now. And one question is, once again, personal opinion, maybe not be immediately backed by trial data, is age. Is there a certain age above which you would no longer consider somebody for atrial fibrillation ablation? Now, based on what Cabana has told us, maybe you want to also throw in CASL-AF, or what are your recommendations, your considerations concerning age?
I don't think we should have an absolute age cutoff, but I do understand that an intervention such as left atrial ablation, particularly if it's more complicated than just pulmonary vein isolation, is a very significant invasive procedure. And frail elderly patients are obviously not best suited to such a solution. So that said, I don't actually have an age group that I will not consider ablation above, but on the other hand, I'm much more prone to offer ablation to the younger patients. And I think in my practice, I mostly stop at around 75 or something of that sort, but certainly I've seen series of patients going into the mid-80s who are being ablated. But my own preference is that it's a procedure predominantly for younger patients with a lifetime potentially of atrial fibrillation ahead of them. Interrupting it early may well free them from atrial fibrillation for a considerable period of time.
We all have the feeling that if you catch it early, it might be more effective. Right. That was not addressed in the Cabana trial, I guess. We do know, based on Cabana, that it does improve quality of life. That's what you showed very clearly.
Yes.
And quality of life is obviously important. If you think about TAVI, whatever you want to call it, quality of life is important even to the elderly, obviously.
Of course it is, yes. And I don't object to managing quality of life and trying to improve it for everyone. But you saw in the data I showed from the Cabana sub-study that even patients treated effectively with drug therapy have a significant improvement in their quality of life. It wasn't as good as with the ablation procedure, but remember, elderly patients tend to have more underlying heart disease, worse left ventricular function, bigger atria, more atrial fibrosis. They're more difficult to manage. That doesn't mean that some of them can't be managed very effectively with ablation, but you have to bear all of that in mind before making clinical decisions.
Well, thank you, John. Very important insight. The topic of ESC Congress 2018 was valvular heart disease. And one of the major trials around valvular heart disease obviously was the MITRA-FR trial, which we discussed, and Roxana gave us the details. Lots of questions coming in around the MITRA-FR trial because you used the word shocked. You were shocked about the outcome.
I really was.
And the questions now are a little desperate. Is there any subgroup, for example, that can be teased out for which the procedure might be beneficial?
Yeah, so obviously this is another excellent question, even though you always have to, when a trial is negative, you're not supposed to look at subgroups. So having said that, they did look at subgroups.
And they can generate hypotheses,
to generate hypothesis. And actually the forest plots did not show any benefit whatsoever in any of the subgroups, and they looked at pretty much everyone. So unfortunately, no.
Yeah, several questions coming in with the questions were these patients treated too late. Earlier stages of mitral regurgitation, earlier stages of heart failure. I think you indicated that the future trial might answer this, but what is your opinion based on what we know right now?
Yeah, I mean, I think if you look at this, when the disease is so far gone that now your treatment is not going to have an important impact on the endpoint you're looking for, you're not going to have an important benefit on top of.
Right.
The fact is that medical management actually did help, with reducing MR. Whether or not the natural history of this was at all changed by even the medical therapy or medical therapy with mitral clip is unknown, right? Because we didn't have a placebo arm completely. So we won't know if doing nothing at all at this point with this sick patient population would have made a difference. I do think that it's easier said than done to say now the lesser sick population should get the clip, but I think we really have to establish first that there is some efficacy on top of medical management in some subgroup of patients before you actually project yourself to a lesser sicker population. So it's a conundrum that I think we are facing. I know that I saw a lot on social media. Of course, you hear a lot of talk on social media about the trial, and the naysayers saying, well, maybe it was the follow-up wasn't so good. They didn't do X, Y, and Z. And I just think we need to see, is there another trial that's going to tell us yay or nay? And the second trial is coming up, which is COAPT, which will be presented in about 3 weeks.
Yeah, a lot of speculation also whether a longer follow-up might potentially have changed the outcome.
Absolutely.
If you look at the curves, they were very parallel, and we had 50% event rate after the trial period. So how much?
Very important. These are very sick patients, and not only they have severe MR, they were highly symptomatic, but they also have impaired LV function.
Yeah.
Right.
So
that's bad prognosis to begin with, right?
Yes. Yeah. And so probably
another question concerning longer follow-up. Let's add, many times came in as far as the global leaders trial is concerned. That was 4 weeks of aspirin plus ticagrelor and then 23 months of ticagrelor versus our complicated standard 6 months, 12 months, sort of DAPT regimen.
But I kind of disagree a little bit, because here it's true that on one hand less is more, because the second antiplatelet was stopped after 1 month. On the other hand, the treatment was prolonged compared to the standard treatment. So on one hand,
it was less for longer.
Yes, exactly, less for longer.
And the question that came in more than once is 2 years follow-up too short? Would a benefit, if you look at the curves, if you look at your personal experience, all the tremendous insight that you have concerning this topic, do you think that a longer follow-up would have given us positive results?
Actually, it's very interesting. What a great crew we have listening to all of this.
Absolutely.
They're sending us
Fantastic
great questions. They're extremely engaged at this late hour. I'm so impressed. But honestly, if you actually look at this, the issue with the trial was the ability for the patients to stay on that experimental treatment. And it was best at 1 year. By 2 years, by 24 months, the experimental arm had about a 23% dropout. 22% of those patients no longer were on ticagrelor monotherapy. We don't know what they were. Yeah. That wasn't presented, but I think that they either went back to clopidogrel or the doctor decided to switch it off to aspirin alone. I don't want to. What's the point of 24 months? The shorter is better. All these things. So, but at 1 year, actually, which was not the primary endpoint of the study, but Professor Sorois did show before he showed the primary endpoint that this trial was positive at 1 year, superior with this mode of treatment. But you cannot look at that. It's not been powered. It was probably, you could argue it shouldn't have even been shown. We really need to go to exactly what the trial was powered for at the time that it was powered for. And
that's the message that's coming back, right? If you design a trial, if you interpret a trial, you should look at the primary outcome.
Stay at that
and don't get lost in sub-analysis.
If you're moving long term, then you're moving into a compass type of patient, aren't you?
Right, and not only that, I think you're moving to compass type of a patient, that you might be switching back now to a novel oral anticoagulant with 2.5 milligrams PLBID with a reduction in mortality compared to a standard of care arm from Compass, but that was only aspirin alone. It wasn't another dual antiplatelet therapy, as you all know. So it's complicated, because here for the first time, the treatment that they are supposed to stay on forever is not aspirin, but ticagrelor. Yeah. So it's a very interesting dilemma.
The questions actually, again, more than once, people are looking for your expert opinion is there any patient in your personal practice for which the results of global leaders would make a difference? Is there any patient where you would change things about? Which would be that patient?
I think 100% that there are. We need to do better, and I don't want to. I really have to say I'm biased because I am the global PI of the Twilight study, which is a prospective 9,000 patient study. 7,000 patients have been already randomized to a double-blind placebo-controlled fashion of withdrawing aspirin and putting the patients on aspirin plus ticagrelor plus placebo versus aspirin plus ticagrelor. I believe the patient population we chose for Twilight are perfect for this. This is ACS or stable patients with complex disease, complex patient population. We have about 40% diabetics, multivessel disease, multivessel stenting. These are the patients in whom you want the potent agent, but you're afraid of the bleeding. So if I get rid of the aspirin, maybe I can still have the benefit of the ischemic protection without the GI sloughing from the aspirin. So we'll see.
Pick the
That's
right
next year.
treatments.
Next year at this time.
Yes,
Next
and I
year
think
this time.
one other very practical issue is that for some reason you have to drop aspirin in a patient who is on clopidogrel. You should do it without any worry. And actually, was the stent thrombosis rate was very low, 0.8% at 2 years. So anyway, this is already a very important information. Should you have to drop the aspirin, is not an issue.
We have
But
a
it's
few.
so close to being significant. Do you think we need another larger trial? I mean, it's so close to.
It is close, but it was not significant.
Yes, but I mean, maybe they were
I
being
mean,
too.
that's what I said. It's a very, very negative study that's going to have a very, very large impact, I think, in the population I just talked about.
Yeah.
But we're hoping that people will wait for twilight before they would do that.
I would like to address two more questions to you, Marco. One is culprit shock has obviously been discussed intensively in the groups out there. Culprit shock, the patients have very, very high event rates. And some of these lesions in multivessel disease might be easier to address than other lesions. And if you revascularize the circumflex, for example, which is the culprit lesion, and then you have a type A lesion in the proximal LAD, and that was the specific question. If you have a type A non-culprit lesion in a major vessel proximal vessel segment, would you still leave it alone? Or would you then, if you think it's an easy target, go for that one?
Yeah, no, I think you should leave it alone. And so the guidelines are now clear. There is a class 3 indication for complete immediate revascularization.
Routine,
clearly. And now, but then again, on a case by case, this is there you have the door open. But these are very selected cases. For example, you cannot identify who is the culprit. Then you are free to go and treat all the possible culprit. Or sometimes you may have multiple culprits. Then you should go for it.
Yeah.
But as a general rule, really you should stick to the culprit.
Yeah, my personal feeling as an interventionalist is if there's a stenosis, but if there's normal flow, what gain are you going to get, right? You have obviously oxygen
you may get no
being
reflow.
delivered.
You may get no reflow, then you are in
to the
trouble.
myocardial segment.
That's very different, though, than in not a patient in shock. Just a STEMI patient who presents with multivessel disease. Now that's a whole different ball of wax that we're trying to figure out, right?
Yeah.
What to do, whether we just go for the culprit or we do complete revascularization. It looks like we're moving towards the complete revascularization, but we'll see. The complete trial is coming out, ACC.
And SCAT, finally, was also tremendously discussed. Montenegro is asking, what is the reason why this is so much more frequent in women than in men? It's a good question, but it's a difficult question.
This is a great question. So actually, as underlying condition, fibromuscular dysplasia was found only in 1/3 of the patient, although we have to say that in SCAD, approximately 50% did not have a complete workup in terms of fibromuscular dysplasia. But we know that fibromuscular dysplasia is also more related to women. So what is the underlying pathology of the wall? I personally cannot tell you.
Hard to say, yeah.
What about the relation to stress and psychological stress?
Yes.
What were the precursors of the...
Yes, exactly. So they looked also whether there was precursors in terms of psychological stress or physical stress, and they could identify in 50% of the cases, the patient described an unusual psychological stress,
but then
and approximately 25% an unusual physical stress. But these are very subjective.
Then what is the control group here? You know, who doesn't have psychological stress?
Exactly.
Yeah. The spontaneous dissection being the Takotsubo of the coronary vessels, maybe. Any group at particular risk within the women? That's another question that came in. We know women that are at higher risk, but among the women, which ones are particularly high?
Two groups were identified and found to be independent predictor of poor outcome. The one was the patient with postpartum spontaneous coronary artery dissection. We saw that the event rates at 30 days were approximately 8 to 9% in the overall group, but they were 20% in those patients in the postpartum phase. So these really are patients that are at very high risk. And then also patients with underlying connective tissue disorder, which also is a minority of all, but this was also found to be independent predictor of poor outcome.
A final question coming in from Russia. My friend Simon is moderating this, obviously, expertly.
Hi, Simon.
Thank you for doing this. We have this very good question. We say that this can be managed conservatively.
It should, actually.
It should be managed conservatively in general, but what is the conservative management? What does it constitute of?
Yes, obviously there is no randomized data and there is only consensus, but we can say from the Canadian experience, we can say that the treatment at discharge, virtually all the patient had aspirin, and 2/3 of the patient had the clopidogrel, in addition to beta blocker.
Why is that? I mean, there's no plaque erosion, there's no thrombosis involved, there's no stent that was placed.
Yeah, this is generally the consensus is you should treat the patient with antiplatelet agent. And so, for example, this is completely different as in the cerebrovascular tumor where people tend to be anticoagulated. We don't know exactly why. But in the coronary here, again, anticoagulation was given in less than 5%. So in absence of new data, I would suggest to stick what most of the people are doing, do antiplatelet therapy, at least for the first phase of the disease.
Well, thank you very much, Marco.
Could I ask, any relation to complications to the pregnancy? Preeclampsia, hypertension?
This is a good question. We don't know. It's not described. We know that 1/3 of the patients were hypertensive, but this has not been described.
Spontaneous coronary dissection, not for the least due make the physicians aware of this condition.
Actually, there is also a European registry you mentioned that is addressing this.
Yes.
Good.
And hopefully with contribution from all over.
Yes,
Excellent.
Especially the countries who
It's
are
a global
attending
issue.
tonight.
We need to look at this more carefully.
So with that, I would like to sum up this round of discussion by saying that, you know, there are so many issues that we have learned at ESC Congress 2018, so many points that were discussed expertly by you in this fantastic round that we had this afternoon, but still so many issues that need further investigation. This never seems to stop. So thank you very much, Marco, Roxana, Eva, and John, for your help in discussing these aspects as thoroughly as we could. Thank you, everybody in the audience, for following us, for sending in expert questions, and for making this moderation and this discussion more lively, and really helping each and every one of us to learn more about cardiology. And we all look forward very much to see you in Paris in 2019 when we come together for the next ESC Congress. Thank you very much for your attention and have a nice evening.
Уважаемые коллеги, вы рано, все рано, у меня самолет в 8 утра, у нас куча времени, чтобы обсудить. Юрий Владимирович, я хотел как раз вас попросить сказать 2 слова.